Good afternoon and welcome to this bill hearing for the House Health Committee. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. We do have a few virtual speakers today, I believe, so please bear with us as we switch back and forth with the tech. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as these meetings can run long, and we're a big believer in hydration here. Please make sure to turn off your phones or turn them to silent at this time. If you see that we have a member who's not present, they are in other committees defending other bills. They may have other meetings, but they are staying informed on our proceedings. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please keep your questions shorter than the answers. We are going in this order today. So House Bill 529, followed by 520, 813, 625, 535, 672, 882, and 860, subject to change as needed. Also, please bear in mind that sponsors are not time limited, but please keep your testimony within reason. And all witnesses on the bills have 2 minutes. We are going to start with House Bill 529. This is the Speaker's bill and Code Revision Health Maryland Medical Assistance Program. We have Jody Chilson here representing our Madam Speaker. Ann Seacott, are you also on this panel, or are you next panel? Next. Okay, got it. All right. So if you want to begin your testimony.
Sure. Good afternoon, Chair Bagnall, members of the committee. My name is Jody Chilson. I am the Assistant Manager of Bill Drafting and DLS, and I'm responsible for signing and reviewing all the health legislation. HB 529 is a non-substantive code revision bill that makes Section 15103 of the Health General Article more user-friendly. That section is one of the main sections in code that governs the Maryland Medical Assistance Program. And over time, it has become quite long and unwieldy. It covers a wide range of topics, from the services required to be provided by the program to the Maryland Medicaid Advisory Committee to manage care organizations. The bill makes the section more user-friendly by moving the provisions governing the advisory committee and managed care organizations to their own sections, splitting up provisions that govern both Medicaid and the Maryland Children's Health Program so that those governing MCHIP are reflected in the subtitle that govern that program, and making other non-substantive, stylistic, and clarifying changes. Drafters' notes are included in the bill to explain various changes that are made. I ask for a favorable recommendation, and I am happy to take any questions.
Thank you very much for your testimony. And am I correct, this is the first time you've appeared before this committee?
I was up here for the mandated reports bill that we do a couple years ago, so I'm not totally new, but I don't show up that often.
All right. Well, thank you very much for joining us in our committee. Are there any questions for this witness? Vice Chair Cullison.
I apologize, Madam Chair, but I don't have a question. I just want to thank you. You know, the work you do on these health bills, and, you know, we appreciate that there are probably like 3 weeks when you don't sleep. So right. You and your team don't sleep. So thank you very much for your work on this.
You're welcome.
Isn't that so? Seeing no further questions, thank you very much for your testimony. And we do have a favorable panel. Ann Seacott.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott with Public Policy Partners. I am testifying in favor of this bill with a thank you. This is a thank you to Ms. Chilson, the folks at DLS, the staff, and the committee members of this committee and many other committee members who for years have heard me seek change in our language. The language we use is so important. And part of what this code revision does is take out words like substance abuse and substance abuser and replace with the more appropriate clinical term, substance use disorders. And so I'm just here as a thank you to everybody involved in helping advance that language and reduce stigma.
Thank you very much for your testimony. Are there any questions for this witness? Delegate Shalega.
This may be for Jody, sorry. But Ann, you may be able to answer. I see quite a bit of language on the express lane eligibility program. Is that new, or are you just codifying that?
That was an instance where there was language in the Medicaid section that applied to Medicaid and M-CHIP, and so we just tried to deal with that so it was reflected in both places, the M-CHIP code. So the language that you see in bold small caps is just a duplicative version of what is already in code. We just put it in the M-CHIP section so it was clear that it covered that piece as well.
Okay, yeah, it's all caps, so I just want to make sure it's not creating a new express lane eligibility program. That's not a new program.
Yep, not a new program. Just, it's current law, we're just putting it so it's reflected in both the Medicaid law and the M-CHIP law.
Thank you.
So, yep.
Thank you very much. Thank you for your testimony. And we have one unfavorable witness, Laura Bogley.
Thank you, Madam Chair, members of the committee. I'm Laura Bogley, Executive Director of Maryland Right to Life. We're actually seeking an amendment on this bill, but without the amendment, we would recommend an unfavorable report. With the proliferation of lethal abortion drugs, which now account for nearly 3/4 of abortions in the U.S., the state of Maryland has a duty to ensure that chemical abortion is safe. But this bill could force taxpayers to reimburse pharmacists through the Maryland Medical Assistance Program for providing these lethal abortion drugs to women and others without a doctor's examination or any other patient safeguards. This bill also has a dangerous companion bill being heard today in Senate Finance to allow all pharmacists to prescribe these abortion drugs directly. The profit-minded abortion industry claims that chemical abortion is safe and easy. The truth is that chemical abortion is 4 times more dangerous than surgical abortion. And a new report proves that at least 11% of women experience serious complications from these abortion drugs. With the approval of abortion drugs, the demand on emergency room personnel to deal with serious abortion complications has increased by 500%, increasing medical scarcity we already suffer in this state. By reimbursing pharmacists to distribute abortion drugs or even to prescribe these drugs without oversight by a physician, the state will be putting women's lives at risk. For example, underestimation of gestational stage may result in higher likelihood of failed abortion, which becomes a medical emergency that could be lethal. Undetected ectopic pregnancies may rupture, leading to life-threatening hemorrhages. These are things that pharmacists are not trained to care for or treat. There's also the risk of abortion coercion. We're seeing many incidents across the nation where partners, spouses, are forcing women to ingest abortion drugs without their knowledge or consent. By making them accessible through pharmacists, anyone can get these dangerous drugs. So we ask you to put patients before politics and amend this bill to exclude its application to reimbursing pharmacists for abortion drugs, which is already happening in Maryland through places like CVS and pharmacists, where they are certified abortion providers. Thank you.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 529. We're now going to turn to House Bill 520. This is State Board of Physicians, Neuropathic Doctors, Scope of Practice, Renewals, and Professional Liability Insurance. Vice Chair Cullison, if you would like to approach the table and bring your panel. And you can get started whenever you're ready.
Good afternoon, Madam Chair, and my friends on the Health Committee. I am certain I am going to owe you at least one dinner before this session is over. You will see me at this table a lot, but this is a bill that is near and dear to my heart, so I hope that you will listen carefully and keep an open mind. You know, I've been proud to serve on this committee for 16 years. You know, our goal is always to improve health outcomes for all the Maryland communities, making sure that we have effective, efficient, and an integrated healthcare system. And that's an important point, that it has to, we are looking for integration across all kinds of services. With the bill before you today, the committee has the opportunity to advance the work that we started in 2014 with the passage of the bill that provided licensure for naturopathic doctors. Last year, we took another step by seriously considering adding prescriptive authority to naturopathic doctors. Well, that bill didn't pass. We followed the direction of then Chair Pena Melnick and convened a work group that included naturopathic doctors, MedChi, and the Board of Physicians. We spent focused time in the interim answering questions and addressing all of the concerns raised by the stakeholders. We discussed the education of naturopathic doctors, both in the classroom and in clinical rotations. We discussed the scope of naturopathic medicine and how naturopathic doctors are part of patients' care teams, including physicians, advanced practice nurses, and therapists. We discussed how naturopathic doctors have prescription authority in other states with virtually, and this is really important, with virtually no history of any disciplinary actions, particularly related to prescription authority. After these thorough discussions, I crafted a bill that addressed all the questions and concerns that I had heard, and it worked partially. The Board of Physicians moved from neutral to support, which you'll see in your packet, and you'll hear from later. And in my long history of serving on this committee, I know that this does not happen all the time. Despite my best efforts, though, and the compromises we made in last year's bill, MedChi remains at oppose, as does the Board of Pharmacy, and I'm going to address those both specifically. As a recap, I want to describe the existing law and my proposal this year, including the compromises that we've made. Under current law, naturopathic doctors may prescribe medications and devices from a formulary. But the statute restricts that formulary to simply 4 items: diaphragms, cervical caps, oxygen, and epinephrine. I'm not sure what percentage of Marylanders can have their health care needs met simply by these medications, but it's safe to assume that this list is too limited to help nearly anyone. Last year's bill eliminated the formulary altogether and provided, and I'm going to just say NDs, since to save a little time, with prescriptive authority for medication within the scope of naturopathic medicine for medications and controlled dangerous substances, Schedules 3 through 5. I just want to note that the bill never, ever included opioids. This year's bill includes compromise language. The bill provides prescriptive authority for non-controlled medications within, and again, I'm going to emphasize this like 500 times between now and the end of this testimony, within the scope of naturopathic medicine. They are not going to be prescribing things that are outside of their scope of practice. I'll tell you, I was at a MedChi breakfast where I heard a primary care doc say, if somebody came to me with this particular issue, I'm not qualified to address it. I refer to the physician who is able to address it. Naturopathic doctors do exactly that. They will refer out to the appropriate provider when it is not within the scope of their practice. But for Schedule 3 through 5, the bill restricts prescriptive authority only for those medicines approved by the Board of Physicians. I want to tell you about where we started and some background numbers. There have been 10 years of safe practice of NDs over the 10 years they've been licensed, and the board reports that NDs have nearly no disciplinary action issues in Maryland. Almost none. In fact, I think I remember there were only 2, and those are people who were practicing naturopathic as a naturopathic doctor without a license. Had nothing to do with medications. think this demonstrates an extremely safe track record. 24 states licensed naturopathic doctors, 14 states recognizing their prescriptive authority. Over half the states, including the District of Columbia, that license naturopathic doctors provide prescriptive authority in their laws. Maryland is behind other jurisdictions in recognizing the full benefit of these providers for our residents. Zero, again, that number is 0 disciplinary actions for naturopathic doctors for prescribing in most states. According to the Federation of Naturopathic Medicine Regulatory Authorities, most states that recognize prescribing rights for NDs have 0 disciplinary actions. These include Hawaii, Idaho, New Hampshire, New Mexico, Utah, Vermont, Montana. We're not talking about one color state, we're talking about many colored states. There are several other states with very high numbers of naturopathic doctors that report between an average of 0.1 to 2.1 disciplinary actions in a year related to prescribing. These are big states: California, Oregon, Arizona, Washington State. Their small number of cases reflect opioid prescribing issues, and we would see similar issues for any kind of health professional with prescribing authority. Thus, we have a PDMP. Consistent with Maryland's practice of recognizing prescription authority of other advanced practice clinicians without a residency program, I've frequently heard that Maryland should not provide prescribing authority to naturopathic doctors because they don't have the same residency program requirement as physicians. However, Maryland has a long history of recognizing the prescribing of other practitioners who have the pharmacological education and experience, but not a medical residence. These include nurse practitioners, nurse midwives, licensed certified midwives, clinical nurse specialists, and physician's assistants. 141.5 hours in didactic pharmacological education. Naturopathic doctors go to 4-year medical graduate programs. They must complete 141.5 didactic hours in pharmacological education and at least 1,200 hours in supervised clinical practice. You may hear from opponents that naturopathic doctors do not have sufficient education, and I would ask the committee to look at the requirements. There are only 60 naturopaths in Maryland today. Only 60 after 10 years of licensure. We heard last year that NDs left the state because they could not practice to the full scope of their training. There are about 8,000 NDs nationwide. Naturopathic doctors don't want to practice in Maryland because of the restriction in prescribing. My panel is going to speak to some of their experiences. The Board of Pharmacy raised issues about the lack of a residency program and the lack of training. I'm going to remind you, as I just said, in terms of the number of people, the number of qualified, licensed healthcare professionals that we now allow to have prescribing authority without issue. You know, nurse practitioners are not seeing a lot of issues. Certified nurse anesthetists are not seeing issues. Without issues. I'm going to remind you that in 1979, we gave nurse practitioners prescribing authority. In 1979, that was before they had independent practice, and they got prescribing authority. Nurse midwives have had prescribing authority since the 1980s. It's 2026. It's time to recognize the full scope of education and training of naturopathic doctors for the benefit of our residents. I'm sponsoring this bill because I believe we're missing thousands of opportunities to ensure Marylanders access to seamless health care. We will hear from NDs today. Each of these clinicians treats Maryland patients, and each and every day their patients must navigate a complex healthcare system if they need a new medication or an adjustment to their existing prescription. They can go to their ND, whom they trust completely and who treats them all the time, with a cut on their finger that becomes infected, and they can't prescribe an antibiotic. So then the person has to go to an urgent care or make an appointment with a GP or a primary care doc in order to get the appropriate antibiotic. If you have to wait for an appointment with your primary care, you could wait months. What happens to that infection then? Sometimes it's an inconvenience. Other times, it's actually harmful. This committee spends a great deal of time addressing complex, multifaceted problems with healthcare access. However, improving access to care for patients of NDs is actually very simple. We just need to change our law to recognize the education and experience of naturopathic doctors in prescribing. I look forward to working with the committee on this bill. I truly thank you for your consideration of all of the facts about the level of training, about the level of accountability, about the acknowledgement of the scope of practice as we consider whether or not we can give this category of healthcare providers that many of our residents want access to, prescribing authority. Thank you very much for your consideration, and I humbly ask you for a favorable report. Am I going to you next? Okay.
So, good afternoon, Robin Elliott on behalf of the Maryland Naturopathic Doctors Association. It's hard to follow Delegate Cullison. She took all my good points, but I'm grateful. I'll just say I've been before this committee many times on other advanced practice clinician issues, and just want to highlight a difference in the educational structure. Advanced practice clinicians do not have residencies in the same way that physicians do. And a lot of that has to do with there is no federal funding. So those educational programs have evolved, they're different. And so what happens is, as you'll hear from the naturopathic doctors today, is that there is extensive clinical experience prior to graduation. And as you'll hear, that involves very careful and deep development of relationships with patients and other providers, and it involves prescribing and understanding what prescribing entails. So with that, I will turn it over to the people who are really expert, starting with Dr. Jillian Casey.
Madam Chair, members of the committee, my name is Jillian Casey. I am a naturopathic doctor with a master's in public health, and I'm vice president of the Maryland Naturopathic Doctors Association. As one of 64 licensed NDs here in Maryland, I'm here today to clarify our training and to shed some light on some of the challenges we face practicing in Maryland. Naturopathic doctors are trained to employ the least invasive modality that is safe, effective, and appropriate for the patient in front of us. In the 14 jurisdictions in which we have prescriptive rights, we are held to the same standard of care as medical doctors. Yes, we use nutrition, we use stress management, lifestyle medicine, wherever it is feasible and appropriate. But we also prescribe medications when that conveys the greatest risk reduction or symptom abatement. Just because a patient already has diabetes doesn't mean that they can't benefit from our care. In fact, it's by employing an integrative approach in collaboration with primary care providers and specialists that our patients can achieve the best outcomes. As Delegate Cullison said, in our 4-year doctoral training, we complete over 140 hours of pharmacology, over 1,200 hours of direct patient care in outpatient and community clinic settings. We pass 2 national board licensing exams akin to Step 1 and Step 2, and 3 rounds of structured clinical exams designed to assess our readiness to enter clinical practice. ND education prepares us to diagnose and treat our patients, though in Maryland, our ability to treat them is limited. This means that when the medication is the most appropriate choice, our patients face significant delays in access. Almost monthly, I speak to an ND practicing in another state who is hesitant to return home for fear of being an ineffective clinician under Maryland's current scope. The bill before you removes an unfounded barrier to improve health care for Marylanders and allow more licensed NDs to return home to serve their communities. Thank you.
Oh, wait, sorry. Go ahead.
Okay. Madam Chair, Vice Chair, members of the committee, I'm Paul Faust, and I've been practicing naturopathic medicine in Maryland since 2001. But when Maryland first began licensing naturopathic doctors, I was honored to receive the first license issued in the state. Licensure has definitely improved transparency and collaboration. I can now order laboratory testing and diagnostic imaging. I can communicate clearly with other providers. But one significant barrier remains. I still cannot prescribe medication for the straightforward needs of my patients. Take as an example, a patient may come to see me with persistently elevated blood pressure. They're sitting right in front of me asking for help. In some cases, they don't even currently have a primary care provider. Sometimes they have questions about medications and simply need time and counseling to understand their options. Other situations I might see are patients who were prescribed a medication years ago and they're now experiencing dizziness or low blood pressure, particularly older individuals who may be at increased risk of falling. Under the current law, I must send these people elsewhere for prescribing or for adjustment to the medications. That often means delay, and sometimes it means they never follow up. This bill allows for naturopathic doctors to provide integrated continuity of care. Upon passage, we would obtain the same required registrations as other prescribers, enroll in required monitoring systems, and use certified electronic health records with e-prescribing that integrates with Maryland's pharmacy systems and health exchange information, including CRISP. We refer when appropriate and routinely collaborate with both primary care physicians and specialists to ensure that coordination. When a patient is already under our care, coordinated, documented, accountable prescribing strengthens that collaboration rather than fragments it. Thank you.
Good afternoon. My name is Dr. Danielle Lewis, and I appreciate the opportunity to speak with you all today. Since 2014, I have taught gynecology at Sonoran University and practiced as a naturopathic doctor, where I focus on women's health and primary care. In Arizona, where I have full prescriptive rights, I have had the privilege of treating several thousands of patients. I moved to Maryland to be closer to family, but since relocating, I have faced significant challenges due to the restrictions on my scope of practice. While I can order labs, I am unable to make simple medication adjustments or prescribe necessary treatments. As a result, my patients are often forced to wait months, sometimes up to 6 months, to see a primary care provider or a specialist for something that I could have easily managed in my office. For example, I had a patient experiencing fertility issues whose lab results indicated hypothyroidism, an issue I see often and have treated often. The simple solution would have been to start her on thyroid medication so she could continue on her fertility journey. Instead, I had to refer her to an endocrinologist who had a 3-month wait. She had already been trying to conceive for over a year. This kind of delay is unnecessary and avoidable. Because of these restrictions, I have seriously considered not renewing my Maryland license. In fact, I continue to travel back and forth to Phoenix to see patients. Several colleagues have reached out to me about practicing in Maryland, but when they see the limitations of our scope, they decide against it. Maryland needs qualified naturopathic physicians, but these restrictions make it difficult to attract and retain providers. Thank you.
Thank you very much for your testimony. Are there questions from the members for this panel? Let me start with Delegate Kaufman, followed by Delegate Hutchinson.
Yes, Madam Chair, thank you. Thank you, and Madam Vice Chair, I have a question for you. And that is, I'm sure we're going to hear from the physicians that this bill can't pass because of patient safety, and patient safety is at risk. But you've indicated, I think, that there are 14 other states that grant prescription authority grant prescription authority to neuropathic doctors. And have you heard a lot about, calamities or major medical issues in other states? I'm just trying to figure out if based on the experience and your research into other states, if the fear about patient safety is based more on fear or fact. So if you could talk to us about whether, there have been major problems with the expanded authority in other states, that'd be great.
Thank you, Delegate. And the first thing I want to say in response is there's plenty of work to go around. This is not taking work from anyone else. So I just thought I wanted to make that point, and you gave me that opportunity. In the states where there are smaller numbers of NDs, naturopathic doctors, there are almost no instances of challenges, calamities, as you said, and that are disciplinary actions related to prescribing authority. In states where there are large numbers of NDs, some of the bigger states, you'll see a 1 to 2% of issues around just prescribing authority, and most of them have to do with the use of opioids. So that's a common theme through all healthcare providers, is where we run into struggle sometimes. So no, the answer to your question, Delegate, is no. There have not been significant issues in other states that provide this prescribing authority.
May I have a brief follow-up? Yes, and my other question is, if your bill passes, we are all about autonomy for patients and different things, but wouldn't the passage of your bill lead to more autonomy for patients because they'll have more of a say of who provides them health care?
The simple answer is yes, and that's one of the things I'm trying to provide.
Thank you, Madam Chair.
Thank you. Delegate Hutchinson, followed by Delegate Ross.
Thank you, Madam Chair. Just to start out with, though, I need a point of clarification from the Vice Chair, and that is that in the fiscal note, it says that this legislation has not been introduced in the last 3 years. That is not correct, right?
That is not correct.
Okay.
You guys drilled me last year.
I'm pretty sure I wasn't having deja vu here, and a lot of the panelists look very familiar.
Right.
So my question to Dr. Casey, describe to me, like, what type of patient wants to come see your practice, versus a primary care physician? What is it about your practice that says they want to come there? If they do then come and be treated, could you admit them to the hospital if there was a more serious issue that you couldn't treat?
Thank you for the question, Delegate. So I require my patients to have a primary care physician, so I'm not providing their primary care. They're coming to me when they have issues that are either falling outside of kind of our diagnostic algorithms or that are early in a disease kind of state. So we have diabetes, for example, and we also have pre-diabetes. This might be a time where we don't need a medication, where we can change lifestyle, or it might be that using something like as simple as metformin can help get their blood sugar under control before it progresses and before there are other sequelae of that disease. We also see a lot of patients who are moving through the lifespan, through the menopausal transition, who are looking for hormonal support. That's an area of expertise for naturopathic doctors. And to your question about hospital rights, no, we do not admit patients to the hospital. So we're trained to recognize the same red flag symptoms as medical doctors to determine when something is urgent or emergent and requires hospitalization. If that were the case, we'd be calling 911, or we would be making sure the patient gets to an urgent care depending on the level of severity. But we are not admitting, we are working in outpatient settings, and we're not seeking hospital rights.
Sorry, Madam Chair, but I do have a follow-up on that. So you say you work with a primary when you have a patient. Mm-hmm. Is that a collaborative relationship, and couldn't you just have that primary physician do the prescribing if necessary?
Well, for example, one of the primary care physicians that many of my patients goes to see does not do hormone replacement therapies, so we wouldn't be getting menopausal support at that primary care office. I collaborate with primary cares who may not be treating something such as prediabetes, or they might be more focused on when something has reached the level of a diagnostic code that we haven't yet hit. So I collaborate with them, especially when something's outside of my focus area. That's the same way that I would send someone to any other specialist if it's outside of my training or outside of my focus area.
Great, thank you.
Delegate Ross, followed by Delegate Riley.
Thank you, Madam Chair. Thank you for this presentation. I'm still learning about this area of medicine, and I feel like I just got maybe a master's from Delegate Cullison on the issue, so thank you. Can you just help clarify how some of the clinical experience that these doctors have as it relates to pediatric cases? I don't know anything at all about that, and if you could just, if you know the, what percentage of Maryland naturopathic doctors focus on pediatrics?
Yeah. So our training is through the lifespan, but we are not pediatricians, right? So again, if I have a pediatric patient, they have a pediatrician. That's where they do their well child exams, their sick exams, their vaccinations. But could I help them if they're experiencing eczema? Or if we need to test for food intolerances, there are pieces where I can step in and support, but I don't replace the pediatrician, and that's not what we're seeking to replace here.
Okay, and mostly, if I may, I'm sorry, this is mostly what I'm trying to figure out is the experience level, the clinical experience that most NDs would have with diagnosing issues in children. And so if you do know what percentage of doctors here in the state of Maryland have pediatric or focus on pediatrics at all, that would be helpful.
So I don't think that we have that information directly. I mean, they are very similar in scope to a general practitioner or to a primary care docs, but not specializing in pediatrics, as Dr. Casey just said. But there may be some who have more experience in it than others. But the scope of practice would still be limited to their scope of practice in terms of what they could potentially do within that context.
Okay, similar to a general practitioner.
Right.
Thank you. Thank you, Madam Chair.
Delegate Riley, followed by Delegate Hill.
Thank you, Madam Chair. So I was kind of looking, because you were saying that, the medical physician and the naturopathic are kind of on the same level in order to be able to subscribe these prescriptions. So I was kind of looking at the differences, and you mentioned they both go through 4 years of schooling. But I see an actual physician or even a primary care would go through actual training at a clinic or at a hospital setting. I don't see that naturopathic doctors do. So that was one thing. And so if you could explain how, the difference there, and also, I believe what I'm reading is that they basically, when they go to medical school, because it is a medical school, I'm taking that away, a medical school, it's basically a study of basic sciences and on nutrition, herbal medicines, homeopathy, lifestyle medicines, but nothing to do with like a prescribed medication that an actual physician would do. But yet, you want authority to do that. So can you explain that or clear it up for me, please?
Yeah, thank you for the question, Delegate. I think that first, with the basic sciences piece there, that's what we call the first 2 years of a medical doctor's school or a naturopathic doctor's school. So this is where, after taking pre-med coursework, we're now focusing on what is normal function, right? This is where we're in cadaver lab, we're learning anatomy, we're learning physiology, we're learning more biochemistry, immunology. These are what we call the basic sciences or the clinical sciences. We take a round of licensing exams after that. And then this is really where we see a big difference, is that we move into the second 2 years, which is really more akin to other advanced practitioners, where we are focusing on taking on an increasing level of responsibility exclusively in outpatient settings. So we don't train in hospitals, but we spend our third year of the program as what is called a secondary intern. Our final year is a primary intern, where we spend 12 months following our own patient panel under the supervision of our attending physicians. So we train in clinical settings that are largely supporting Medicaid patients, which means we're seeing a lot of kind of comorbidities or a lot of complex chronic conditions. These are patients that even if we weren't the ones to write the prescription, we do have to understand what that prescription does and how it interacts with other treatments that we may want to use. So we're uniquely trained to understand those drug-drug as well as drug-herb or drug-nutrient interactions. And to the question about pharmacology and where does that sit, when we learn sort of in an organ system model, so we'll have a cardiology or a lung pulmonology course, that's where we're going to learn all the diseases as well as all of the treatments that we want to be prepared to see in a primary care or outpatient setting. Those treatments include the prescription medications, because again, whether we were the one to prescribe it or not, that's what many of our patients are going to be taking.
Okay, so a follow-up, Madam Chair. So basically, so you're saying you're getting that training through your 4 years of
Through our 4
schooling
years
for-
and through our licensing exams, yes.
Okay, so are your exams, to follow up, are your exams identical to what a medical physician goes through and passes?
They're not identical. I don't think those exams get released publicly. Those are all, because of cheating and such, we don't get to see those exams. They are designed to assess our readiness after, so the 4 days of exams we take after graduating, our readiness to enter outpatient clinical care.
Thank you very much, I appreciate it, thank you. Delegate Hill.
Thank you. Thank you very much for the bill. I guess I want to pick up, I think where Delegate Riley was. Just a point of clarification, are all the naturopaths licensed in Maryland coming from the same training background? In other words, I have heard, and again, it's not my area, but I have heard that there are some naturopaths that go through the 4-year graduate level training. Some are traditionally trained and don't have that same thing, so that there's this broad range. So if we say all naturopaths can now have prescribing authority, we're actually talking about a broad range of people. Some have experience and some don't. Is that a fair statement?
Thank you so much, Delegate Hill. I'm really happy to get to clarify this. This is a common point of confusion, and it's very understandable. What I'm so grateful for, having come here after our license bill passed, is that we've created patient protection by defining in the law who is a naturopathic doctor, who is eligible to get a license, and who is eligible to use the title naturopathic doctor in the state of Maryland. Anyone who is legally using that title in the state of Maryland has graduated from one of the 6 accredited naturopathic medical schools. There are folks who are what we call lay naturopaths. So since our license bill in 2014, they are not allowed to call themselves naturopathic doctors. They may be doing so. They've not attended 4-year clinical programs. They have not been trained in the ways that we have. Those programs have been around for a long time. They might share some interest areas where people might think, oh, I want to see a naturopathic doctor, and I'm seeing one. That's what was so important about the 2014 work in achieving that distinction. So no, folks who have not graduated, who have not passed the licensing exams, who have not applied for a license through the Board of Physicians, they are not going to be gaining prescription rights.
Okay, may I follow up? Okay, thank you. So, and we've spoken before, I've certainly referred patients to naturopaths, had family members use them, and I love the collaborative work because if I or the primary care, whoever's taking care of someone as an osteopath, and I mean, I'd like to advise diet and other changes, and then we get to a point I go, you know what? I'm not the expert in this. Let me send you to a naturopathic doctor so they can do those things. So the vice chair spoke of examples about what if someone has an infection. I just think, you know, that's an easy one to call someone and give an antibiotic. It doesn't necessarily mean prescriptive authority for someone who doesn't usually do that. So here's the question. I know MDs who have broader practices, who've done additional training in naturopathy, gotten degrees in that, so that they do both. And I'm sure there may be some naturopaths who do both. I guess what I'm confused about is why, particularly if they didn't necessarily train and they haven't had the experience, because they haven't been prescribing here in Maryland for the last 10 years or 12 years, but now, so where's the experience for prescribing if it wasn't in training, it wasn't in the last 10 years, that allows them to now start prescribing? Just because we've been doing something for a while, so now we should start doing the other thing, because other people are able to do it.
Thank you. I think when I think about this bill, first of all, it's not just for the naturopaths sitting here, right? But it is for the future of healthcare in Maryland. So it's for people who are in school now, right? For students who are coming and precepting with me during their breaks and would like to move back to Maryland, but as of now, their thought is, oh, I won't because I won't be able to practice. So the preparation is those final 2 years. It is being prepared to come out and manage outpatient care. That is where we train to prescribe. If you're speaking of who's already here in the state, that's not as much. I can't speak for every naturopathic doctor in the state. I am licensed in other jurisdictions where I am prescribing. So that's one of the differences as well. I'm not able to do it in Maryland, but I'm able to do it in DC. I'm able to do that in Oregon, in Washington, in California, et cetera.
So if I can thank you. So if I understand you correctly, this bill doesn't have a component that says we will allow prescriptive authority to naturopaths who have it in other jurisdictions or who graduate between 2024 and 26, but unless they've already got authority somewhere else and have been doing it, or unless they graduate in the last few years, we don't think they have that experience, so they are not granted prescription for it. That's not part of this bill, right? It's everybody who since 2014 has been a naturopath, whether they've been prescribing or trained in it or not, are going to be able to prescribe. Is that right?
Well, their training has been the same as the training of someone who's graduated in 2022 or 2023. They've been taking the same licensing exams, and then they've been taking the same number of required CEUs. So we have to take the 50 hours that medical doctors have to take. So we're not talking about someone who went to a different program than someone who's graduating today. I'm not sure if that understands your question. I'm sorry. Okay.
Yeah, it doesn't answer the question. Thank you.
Delegate Lopez, followed by Delegate Alston.
Thank you, Madam Chair. I have a question I think is probably best directed to Mr. Faust. Can you go into more detail about how you work with primary care physicians? That part I'm not as clear about.
Sure, thank you. Yes, we work with primary care physicians all the time. We refer to them routinely, they refer to us, but the reality is not everyone has a primary care physician. So we're often faced with a position where the patient is in front of us, they have a defined need, and it would be straightforward to be able to prescribe to that patient. When they do have a primary care physician, we can reach out in a number of ways. We schedule peer-to-peer phone calls, for case review. We're often on secure messaging apps like Doximity. I text other primary care docs all the time. We have our electronic health records. We can share records that way. So it's I would say very collaborative in that way.
Thank you.
Sure.
Delegate Alston.
Thank you, Madam Chair. I heard you earlier, ma'am, say that you have prescribing authority in DC. Is there anything that would prevent you from taking your Maryland patients to DC and offering them prescriptions?
So they would have to be seen in DC. If they don't reside, if they're not a resident in DC, then they cannot receive a prescription unless the office that they're seen in is located in DC.
So if I'm a Maryland resident and I'm determined to see a naturopath, I can go to your DC office, see you, and you can write me a prescription for my ailments?
Correct. I know several naturopathic doctors who are licensed in Maryland and DC, and they maintain an office in DC in order to be able to exercise their prescriptive rights. Patients then have to travel to them.
Okay. So would you agree then that in Maryland we're losing opportunities because of this?
I would.
Thank you.
Seeing no other questions for this panel, I just wanted to clarify. I know that we started licensing naturopaths 10 years ago, but naturopathic physicians have been around for a long time. Is that correct? And I was looking a little bit online. The American Association of Naturopathic Physicians was established in 1985. Is that correct? So, and we have multiple states now that have licensed naturopaths, and multiple states, to your point, including the good delegate's point, that one of our border districts that you have prescribing authority, correct? Do you know how many other border states or states in sort of the East Coast region already have this prescribing authority? And if you don't, we can take it offline, but I'm just wondering, like, where we are relative to
Yeah, I think I can answer. So on the East Coast, if we restrict to that, it's New Hampshire, Connecticut, Massachusetts, Vermont, and Maine. And DC.
And Washington, D.C. Thank you very much. Seeing no further questions, that concludes this panel. We do have a favorable panel, so if I can bring Madeline DeGreco and Dr. Anna Satak.
Thank you, Madam Chair.
Satak. And you can begin your testimony when you're ready.
Good afternoon, Chair, Vice Chair, and members of the committee. My name is Madeline Del Greco with the Maryland Board of Physicians. The board does not opine on scope of practice issues and does not have a position on whether a naturopathic doctor should be authorized to prescribe or not. But we are here in support of HB 520 operationally. The bill was drafted after a series of meetings held during the interim with a variety of stakeholders. It can be implemented with current resources and without any fiscal or operational impact. We thank Vice Chair Cullison for her commitment to collaboration and for allowing the board the opportunity to be a part of the conversation. Thank you.
Hi, Madam Chairman and members of the committee. Thank you for the opportunity to speak today. My name is Dr. Anna Satak, and I'm a conventionally trained ICU physician, and I'm also a member of the Montgomery County Medical Association. And I was practicing full-time in the ICU during the COVID-19 pandemic. And there we really saw just how much chronic disease contributed to the severity and mortality of patients in the hospital. And it was really apparent that as a healthcare system, we needed to be focusing on chronic disease management before patients got sick enough to need to be in the hospital in the first place. And with that in mind, I think that naturopathic doctors are uniquely suited to provide patients with comprehensive approaches to chronic disease and chronic disease care that is burdening our system. They complete a similar 4-year medical degree, and this includes extensive training in pharmacology. And they also have strong training in preventative medicine, lifestyle, and nutrition training that was honestly not a part of my medical training or my residency or my fellowship. And imagine a patient who's got diabetes, and they're initially hesitant or resistant to pursue pharmaceuticals, and so they seek out a naturopathic doctor. And then they're in front of that physician, and that provider has the education and the background to explain why a medication may actually be good for them and appropriate for them in combination with a number of other things. Without prescribing authority, at this point, that patient then has to schedule other visits with other providers, wait for that delay in order to get access to really basic medications like metformin and metoprolol. And I think that creates an unnecessary and artificial burden to patient care, and that's the kind of thing that can derail and just delay patient care and access. And since the pandemic, I have had the opportunity to work with several naturopathic doctors directly in clinics, and I've always been impressed with their thoughtful and comprehensive approach to patient care. And while I recognize that their training is different than my residency, I have absolutely no hesitation in recommending their ability to prescribe responsibly and thoughtfully. So I hope you support this legislation, and thank you for the opportunity.
Thank you for your testimony. Are there any questions from the members for this panel? Vice Chair Cullison, followed by Delegate Hill.
Thank you, Madam Chair. And first, Maddie, I want to thank you for sitting through 6 hours of meetings on this bill as we prep, and I really truly appreciate the support and guidance that you all gave us in developing the bill. I know you said that the board is supporting it operationally. It wouldn't be supporting it operationally if they believed that there was any safety concerns relative to patients. Am I right about that?
I would defer to the practice experts on that, but I do know we talked about that extensively during the interim meetings.
Okay, thank you very much.
Delegate Hill.
Thank you. I'm going to address this to the doctor, and thank you very much. Absolutely agree, have a lot of respect. As I said, I've worked with naturopaths, and that naturopathic doctors also prescribe and are trained in herbal combinations and things. So whether it's St. John's wort or whatever, and they have certain prescriptive expertise, right?
Yep.
And as a a medical doctor, or osteopathic, whichever you are, would you be comfortable prescribing for your patient a naturopathic remedy with multiple other naturopathic and other medications? Would you be comfortable, since you're able to prescribe the others, would you be comfortable prescribing naturopathic?
Currently, I am comfortable with a lot of things, but that's because of additional training I did in functional medicine. And actually some of the interactions I've had with my naturopathic colleagues. So I pursued extensive additional training outside of medical school because I don't think I learned any of that in medical school. And what we have in med school is basically a patient comes in, they're not sick enough, not sick enough, not sick enough, not sick enough to need a prescription until all of a sudden they do. And there's a big window where somebody's got a sore throat, or like my daughter had an earache last night and was crying and she's 6 and I want to do something, but she doesn't need an antibiotic. It's been like 6 hours. So I put Malarian garlic oil in her ear. And I learned that from my naturopathic colleagues when I was working in the same clinic with them. And it's nice because I'm not worried about overprescribing antibiotics. That happens to be something I learned, and I think that's safe, but I would say the vast majority of physicians don't know that.
Right.
And so we're limited by our toolbox, and our toolbox is pharmaceuticals. And a lot of patients don't want pharmaceuticals, and a lot of physicians recognize this is sort of overkill in this situation. And naturopathic doctors have a lot to offer in that realm, and I just want to highlight that.
Okay, and I appreciate that. And so I guess there's a
Did you want to follow up,
parallelism,
Delegate Hill?
right?
Did you want to follow up?
May I? Thank you. But there's a parallelism that you know what you trained in and you know what your experience is in. And the same can be assumed the other. And you can
Absolutely.
see other people doing things and understand and appreciate what they're doing. And appreciating it doesn't necessarily mean that you have the expertise to do it.
Absolutely.
All right, thank you.
And I routinely recommend, like when I see patients who have oncologic cases, and I know that there are some naturopathic oncologic treatments that can mitigate the side effects of chemotherapy, that is well beyond what I feel comfortable with. And I really appreciate having naturopathic oncologists who have specialized training. It doesn't mean they're telling their patients don't have chemo, but it does mean they have some other solutions to help deal with some of the nausea and some of the dry mouth and the burning in the mouth and just different side effects so that they can tolerate their traditional medical treatments that they're getting from their medical specialists.
Thank you. Delegate Hutchinson.
Thank you, Madam Chair. A question for Ms. Del Greco. I did find that last year there was a similar bill, 867, 5309. Now I lost my track. Do you recall being here last year for that bill? Did the Board of Physicians have a position? Did you testify?
We did not. We were not involved in the drafting of that bill. There were not interim meetings for the drafting of that bill.
So you're I don't know if it's favorable or where or just informational. You're here because there's operational, I see renewals, professional liability insurance in the title here. There's an operational component of that. And so the board is supporting that component of the bill. Is that
That
my
is correct,
understanding?
yes.
Thank you very much.
Seeing no further questions, I just had one question for Dr. Sata. With your experience working with naturopaths, would you say that their practice is patient-centered and that the prescribing authority would be limited to what was in the best interest of the patient as well as their knowledge and scope of practice?
Absolutely. Absolutely.
Thank you very much. This concludes this panel. We do have an unfavorable panel. So if I can bring Von Powell, John Niehoff, Steve Wise, and we also have Amanda Anderson virtually. Okay. So we'll do the whole panel, including our virtual, and then open for questions.
Thank you, Madam Chair. Steve Wise, I'm here on behalf of MedChi, the family physicians, and the oncologists. First thing I want to say is Delegate Cullison worked with us. She and I have talked about this many times over the years. I have the greatest respect for for Delegate Cullison. I have lobbied for 30 years, and that includes on this issue, where we still, unfortunately, disagree. And the disagreement is really a fundamental one. As the committee has gathered, and I know knows from prior years, there is a basic difference in the training of a naturopathic doctor versus a medical doctor or DO. You're going to hear about that from Dr. Dehoff. You're going to hear about that from Dr. Powell. But the numbers, I think, speak to this. Clinical hours of a naturopathic doctor range around 1,200. Clinical hours of Dr. Powell, who's a third-year medical resident at the University of Maryland in family medicine, is closer to 12,000. He works 15 hours a day learning different aspects of the practice of medicine. And that is the fundamental difference in training, and we think such a substantial difference that you can't give the same prescriptive authority to someone that doesn't have that versus someone who does. I wanted to address a couple of questions in my remaining time that came up. One question Delegate Alston asked about was DC. They can prescribe. That's our only surrounding state that allows naturopathic doctors to prescribe. But the formularies in these states vary significantly. DC has one of the more limited naturopathic formularies of any of the surrounding states, and I think you have to understand that not every state has the same formulary. A lot to unpack here. I'm happy to answer any questions you may have, and we'll let Dr. Dehoff go next.
Good afternoon, Madam Chair and members of the committee. I'm speaking on behalf of MedChi, the State Medical Society, and the Maryland Academy of Family Physicians in opposition to the bill. I have 41 years experience as a family medicine physician practicing in Maryland, and also as a faculty physician teaching family medicine residents at MedStar Franklin Square Medical Center, where I've been involved in training over 300 family medicine physicians over the years. So I wanted to talk about 3 points that I think make a difference. The first difference is in postgraduate training. After college, and you're doing your 4 years of medical school or 4 years of naturopathic school, medical school involves working within an integrated healthcare system in the United States. A naturopathic school focuses on natural therapies, which is the foundation of naturopathy. The biggest difference is residency training, which Mr. Wise alluded to, being the 12,000-hour difference in clinical experience versus 1,200 hours. And that's experience that the resident has taking care of thousands of patients in the office, in the emergency room, in the ICU, in the hospital wards over those 3 years. And they're learning drug interactions, what is the right time to prescribe a particular medication for a particular patient, and coordinating care with other physician specialists, not overlapping any kind of drugs or treatments that would possibly conflict. So there's danger in even prescribing simple medications. For instance, like lisinopril, which many people take for hypertension. But there can be a small number of patients that get angioedema, which is swelling of the lips and the tongue, and that can be a harbinger for a more serious respiratory collapse or even death from an adverse reaction to even a common medication. So that's just one example of many, and for these reasons, patient safety being foremost, I recommend that the current law stay the same with the formulary for naturopathic physicians in Maryland and not to prescribe CDS substances. Thank you.
Okay. Good afternoon, committee. My name is Dr. Vaughn Powell. I am a third-year family medicine resident at University of Maryland, Capital Region in Largo, so PG County, where old PG used to be, moved over to now. I'm just going to detail a couple of different things about my training in the last 2.5, going on 3 years now, and I apologize if I start twitching and reaching my back pocket because I'm actually on call. So in general, our program much like most other family medicine programs, you do a lot of formal training, a lot of formal classroom work. We have Tuesday didactics, so we have classroom time. Even though we've spent the 4 years, we've gotten the degree. We took step 1 and step 2, which you'll probably hear about, is the full-on licensure exam, followed by the step 3, which you need to pass in order to complete your residency training. And that's just classroom work. Every day is usually some sort of mixture of how to take care of a patient in the hospital versus how to take care of a patient out of the hospital, and in different modalities. So we do general inpatient medicine, which is when we're admitting patients to the hospital that have very severe conditions. We have ICU training for at least 1 month, where we take care of the most critical patients in the hospital. I'm on call for OBGYN right now, where we take care of our pregnant patients when they come in, and babies can be somewhat uncouth because they don't care about what time they get delivered. So you get into the hospital at any odd hour of the night. And then we take care of those same babies in our clinic, along with their mothers, their fathers, their grandparents, their brothers, and their sisters. We do extensive work with different specialties, usually as a part of our set training, including cardiologists, neurologists, nephrologists, oncologists, and such of the like. And then we do a lot of work in emergency rooms. So in total, we do quite a bit outside of just graduating from medical school, just graduating from undergrad before we can work. Thank you.
And we have one virtual witness on this panel, Amanda Andreessen. Go ahead and unmute, and you can begin your testimony.
Good afternoon, Madam Chair and members of the committee. My name is Amanda Andreessen, and I'm a first-year medical student at Johns Hopkins University. I'm speaking here in opposition of this bill. Just to give a little more context about the medical education, I received training over 4 years in not only pharmacology and clinical indications for different medications, but I will also spend over 2.5 years in direct patient care hours during my clinical rotations. And yet, when I graduate medical school, I will not have prescribing abilities, and that is because we recognize that the residency and training, practical training that goes into it, is required for us to have safe prescribing. I also wanted to share a patient story. So before I was a medical student, I worked in clinical research at the University of Chicago, and I came across a patient in a cancer trial who was a young woman who was diagnosed with stage 4 metastatic colorectal cancer. And we were enrolling her in this clinical trial as kind of a last effort to try to improve quality of life and expand her life time as much as we could. And it was through this process we realized she had been prescribed a supplement from her naturopath, which was interacting with the chemotherapy she had been not responding to the last 2 years. And this points out one of the key things is that this drug interaction basically was reducing the efficacy of her chemotherapy. It's not enough to just be able to have training prescribed in your area. You need to understand the full spectrum of medications that a patient could be taking, and that type of training is what's received through residency programs, as Dr. Powell was just explaining. And so at the end of the day, this comes down to a patient safety issue. Medical access obviously is something that we want to improve, but I don't believe this is the way to do that. It puts patient safety at risk. And just to add in, since I have a little more time, one of the biggest reasons that patients will end up in the emergency room is due to side effects from medications. And so we're only going to see that increase if we allow further prescribing abilities for those who don't have the proper training for it. And for those reasons, I would like to urge you to oppose this bill. Thank you.
Thank you for your testimony. All right, I'm going to open it up for questions from the members. I'm going to start with Delegate Kaufman, followed by Rosenberg.
Yes, thank you very much for your time and your testimony. This is a question for the doctor who works at Franklin Square, the family physician. I forget your name, sir. I'm sorry.
Dr. Niehoff.
Native. Okay. I'm going to pose to you the same question that I posed to Delegate Cullison. In the other states where they have more expansive prescription authority, have there been major calamities, a crisis of people getting sick or having to be rushed to the emergency room as a result of this prescribing authority? Do you have any data? I guess I'm asking any data to back up your assertion that that expanding prescription authority for NDs would not be good for patient safety?
I can't really speak to the point about the possibly inappropriate prescribing in other states. I can speak to the educational differences and to how complex it is to prescribe medications in a primary care practice. We have to sort of know the patient, know the family, know their social context, know what illnesses they have, what their symptoms are, what other medicines are on, what specialists they're seeing. So there's a lot of factors that go into our day-to-day care. And I'm just pointing out sort of like with our training, that's how you get that background and how you have that knowledge to be able to approach someone in a helpful way. And so I'm just not seeing that in the naturopathic training.
Thank you, Madam Chair.
Delegate Rosenberg.
I'm going to ask a different question than I intended. Of what relevance is the social context? I'm not being critical, I'm just being curious.
Sure.
To the prescription of a chemical.
What insurance they have. Do they have insurance? Are they going to be able to afford that medication? Do I have to give them warfarin because they can't afford Xarelto or rivaroxaban as an anticoagulant? And now they're going to have to go every few weeks for a blood test because they can't afford the more expensive prescription. I mean, there's so many factors that come into place. Are they homeless? Do they even have are they living in their car? So there's so many social factors that come into play that when you're deciding what to do.
May I ask a follow-up? And it's your contention that that this bill would allow people without that knowledge and that context to prescribe?
I think there has to be limits, and right now there's a formulary that's part of the Board of Physicians, a formulary council that Delegate Collison alluded to as far as what's on there. You know, I think that's, I don't see just abolishing that formulary. I mean, I think that there needs to be certain parameters. So the way the bill is currently, that we're MedChi and the Maryland Academy of Family Physicians is opposed.
Thank you, Madam Chair. Thank you, Doc.
Thank you. And just for the edification of the body, there in your packet under the Federation of Naturopathic Medicine Regulatory Authorities, in answer to Delegate Kaufman's question on page 3, there is a table of disciplinary actions related to naturopathic doctor prescribing of the states that currently have that prescribing authority, for your reference. Delegate Hutchinson.
Madam Chair, to Mr. Wise, I think you had a list of questions that you weren't able to go through at the end there that you wanted to highlight.
Well, thank you. I do want to respond, if I can, to the information about the complaints. That's where I was going next. While that may be a measurement of how things go when naturopathic doctors prescribe, I really don't think it's a full reflection of how you would measure the outcomes. People tend to progress through the healthcare system, and it may be an early miscalculation, misdiagnosis that doesn't materialize until later. On top of that, not everyone files a complaint. We have 20-some thousand doctors in the state of Maryland. You know, I don't think our complaint rate is very high, but guess what? There are mistakes that are made. The board does discipline people. People do get sued for malpractice. So I just, you know, it's a criteria maybe that you want to look at, but I don't think it is the determinative one. I think the training and experience that helps avoid those mistakes is our message today.
Thank you.
Delegate Warman, followed by Vice Chair Cullison, followed by Hill.
Question was already answered, Madam Chair. Thank you.
Vice Chair Cullison.
Thank you, Madam Chair. And I have to also thank Dr. Niehoff for your 6 hours of time with us. I guess I didn't do my job well enough, but that's okay. So I guess I'm wondering, what you think the difference is between the background experience, pharmacological training, clinical hours of naturopaths compared to nurse practitioners who have prescription authority today and have had since 1979. Would you say that they shouldn't have? They don't do a residency. And to me, that's what you're using as the basis for your decision, is the residency. NPs, and believe me, I am a big fan and champion of NPs. You ask any of them, so I'm not saying anything bad. And they don't have a residency, and they've been prescribing in this state for over 50 years or close to 50 years. Would you say they should not have prescribing authority today?
My wife is a nurse, so I better not say anything bad about nurses. She's been a practicing RN for many years and is now retired from St. Joseph's Medical Center in Towson. But I'm not an expert on the training of nurse practitioners. We have had nurse practitioners in our family health center at Franklin Square, and we require all our mid-level providers to have their charts signed by one of the physicians in the practice. So there's a level of oversight there that was not required by law because of the variability of training from what I've seen from personal experience. So it seems like some nurse practitioners have extensive experience. Maybe they've been working as a nurse for many years before they got their NP degree and are very familiar with many different medications. And there are other nurse practitioners that had just finished their training program. Maybe some of the courses were online, maybe not had that much clinical experience. And they have needed much more oversight and teaching to get up to speed in our practice. So that's sort of my experience with working with nurse practitioners and their prescribing ability, but that's limited, and I'm not an expert in that field.
May I, Madam Chair? Yes, please. But do you agree they don't have a residency?
They
Okay,
don't do a
They don't do a
residency.
residency. But what I heard you say is there's a variation in training. That would probably be true of every single healthcare professional on the planet. The fact that you're requiring your NPs to have sign-off is a factor at Franklin Square. Nurse practitioners have independent practice authority now. So they could be doing this. In fact, federal qualified health centers, they're being run by, many of them are being run by nurse practitioners, again, without incident. So I guess I'm still curious as to why you think that is different than the naturopathic doctors in training.
May I respond to that?
Okay.
Delegate Collison?
Right.
The fundamental difference between a nurse practitioner and a naturopathic doctor is that one is based in medicine as we know it as physicians. The other is based in naturopathy. And so there, again, we come back to the fundamental difference, not disputing your point. No residency for nurse practitioners and they prescribe. But there is, again, a fundamental difference in the basis of their education from a naturopathic doctor.
Delegate Hill.
Thank you. I'd like to address this to the witness. I can't see your name. I don't have the witness sheet in front of me on virtual. Okay, Andreessen. So as I'm listening to this discussion, what I'm hearing is that naturopathic doctors have a specialized training that is different from medical and osteopathic doctors, and vice versa. Medical and osteopathic doctors have certain kinds of drugs, medications, and treatments that they're very familiar with and comfortable with, and naturopaths have a different line of medications and things that they're comfortable with. And that we heard testimony earlier that just as it is inappropriate for a medically trained person to start randomly giving prescriptions for naturopathic treatments without some additional training. It would be equally wrong, except under this bill, for the naturopaths to be given prescriptive authorities for things they're familiar with because the medical doctors they work with do it, but they don't really have that background and training. And so what I'm hearing, and here's the question, is that if we pass this bill, and let's not even talk about the fact that it includes narcotics, but if we pass this bill, the collaborative relationship that both the naturopathic doctors and the medical and osteopathic doctors have talked about will actually be diminished because the naturopaths will have fewer reasons to lean on the expertise of the medical doctors and vice versa, because they'd each be able, despite differences in their backgrounds, to start doing each other's jobs. So there'd be less collaboration. In your experience and your research that you talked about, is that right, that there be less collaboration in your opinion or greater collaboration?
Are you referring to my clinical research?
Yes.
Yes. I can't necessarily speak on naturopaths' collaboration forwards, but I know as far as our training, we were always taught to ask about additional supplements. So for example, when we are looking at someone's medical chart to try to figure out like what their past medical history is and evaluate what medications they've been prescribed or previously prescribed, which is all part of like the decision-making process when prescribing medications, and the other physicians can speak on this more. Naturopathic physicians' notes are usually not going to be in there, and so we are taught to ask specifically about it, and it creates this conversation around it. But if they're prescribing other medications, we might not necessarily see that, and so it would create a communication barrier where we could prescribe something not realizing that they're on that medication, and it could end up having a drug-drug interaction, which, as they were discussing earlier, and potentially adverse side effects, if that answers the question. So I'm not as familiar, since I'm still a student, in terms of like the practicing communication between naturopaths and physicians, but yeah.
Okay, thank you.
Delegate Johnson.
Thank you, Madam Chair. I've got a two-part question for Dr. Niehoff, if you would, please. You had made some statements in your testimony that I wanted to clear up. You talked about the relationship with a doctor and a patient. So are you suggesting that a patient does not have a relationship with the naturopathic doctors? And you also mentioned drug interactions, which I had a pharmacy for almost 20 years. And first we have software that checks for interactions when we put in their profile. Second, there were several times that we had to call a doctor because there were things prescribed that would have an interaction. So are you saying that you made it sound like a regular medical doctor would never have those issues. So can you comment on those two things for us, please?
So let me rephrase that to make sure I have the questions correctly. The second thing was about drug interactions and some of the software that might give you an alert about the interaction. And I think those have to be looked at judiciously, because sometimes there'll be an interaction, at least the software that we had through MedStar, which was built into the electronic record, would sometimes make alerts that weren't clinically meaningfully. Every time we would put certain drugs in, a flag would come up, but for instance, an ACE inhibitor, and there would be an alert that makes sure they're also on potassium. Well, it's because their potassium was still low. They needed to be on potassium. So, so what I'm getting at is you have to look at those computer alerts with your background. So you have to realize some of them are important and you have to pay attention to, and some are just because this computer is going to flag everything in that category, and it may not be important for that patient. And the first part about a doctor-patient relationship, I think with the naturopathic doctor, in the field of natural therapy, the patient does have a relationship with their provider. And that's been taking place for the last 10 years or so in Maryland. And I'm not saying there's not a relationship, but I think, when you're adding on the prescriptive authority, that's changing the relationship.
May I add to that? No. Oh, there's one? All right.
Thank you, Madam Chair. Is there anything you'd like to add?
I think you're, at least towards your second question, we use Epic in our computer system. There are many flags, a lot of times, for many drug-drug interactions. Sometimes for different, I guess, body system or disease drug interactions, there is no flag. And I've learned that more in residency now than I did in school, for sure. So if you have a 87-year-old patient who's diabetic, ESRD on dialysis, hemodialysis Monday, Wednesday, and Friday, and you give them Lyrica for their diabetic foot pain, and then you get kind of confused as to why they get confused and start falling, but you didn't realize that the Lyrica dose that you prescribed is too high for somebody that is on dialysis. That's not something that's going to flag in Epic all the time. What does happen, though, is our attendings flag that before we even write the order. So you can't give that dose or you can't give that medication entirely because of this whole total, picture for this particular patient, although Lyrica has been used for diabetic neuropathy. So we have a lot of those checks and balances, I would say, in residency that you get taught of in theory in school, but you can forget in practice, especially in the heat of the moment.
Follow up, Madam Chair. Thank you. Okay, thank you. So do you think that something like that would fall outside of their scope? Or is there a certain scope that you would feel comfortable with?
Does it fall outside of my scope?
Outside of a
naturopathic scope?
Something they would normally be looking at.
If there is no supervisor that can actually flag those things, especially if they haven't been looking at them, routinely, then yes, I do think that falls outside of the scope. Because technically, if you want to talk about scope, if you are not boarded in a particular specialty, your scope is not really there. You're not boarded in cardiology. Yes, cardiology medicine, but does the board of cardiology actually approve of you prescribing these things? Do they approve of you doing the left heart catheterization? Do they approve of you reading the echocardiogram? I don't think so, unless somebody's trained you to do that. So if there's no training to look at not only drug-drug interactions, but also like disease drug, or like we say, situation drug interactions, that sounds scary to me if my family member were to go and, indulge in that treatment.
Thank you, Madam Chair. Thank you.
Thank you. Delegate Alston.
You know what? If we're done.
Seeing no questions, I have a question for Mr. Wise, because you said something interesting. You said medicine as we know it, referring to the physicians. So I was just wondering if you could speak to what your expertise is in the medicine of naturopathy.
Well, I think it's safe to say my expertise is not in the medicine. I'm speaking on behalf of my clients, but there are fundamental differences between allopathic medicine and naturopathic medicine and osteopathic medicine. We have MDs and DOs, and if they were all the same, we wouldn't be having this conversation because we wouldn't have had to develop a separate licensure path for naturopathic doctors. Different accreditation, different schools, different curriculum, some the same, Delegate Cullison, but not all. If it was the same, this would all be under one license umbrella, and it's not. That was my point.
Delegate Alston.
I just couldn't help myself. All right, so here's the concern or question that's been bugging me throughout this whole hearing. We have other people that have less training and experience than these naturopathic doctors that are allowed to write prescriptions. with little to no oversight from an actual medical doctor. So how do you square it that these folks then can't? Because we actually have a bill pending right now to give physicians' assistants the ability to do that and be primary care providers. We have licensed nurse practitioners. We have so many people who don't have that direct oversight that can write prescriptions with less training and experience than the naturopathic doctor. So what amendment would make you all comfortable giving them the right, or do we need to roll it back from everybody?
So, good question. And let me speak to some of the other professions that I heard about. Physician assistant, okay, is still subject to the collaboration agreement with a physician. So there's a level of control there. And the physician retains the right under the law that you passed 2 years ago to limit the scope of practice, including in areas of prescribing for the physician assistant. Nurse practitioners, I partly answered that question, but I'd also point out to you that there's an additional, I think it's 18 months of collaborative experience required before they can prescribe. If there's others you want me to go into, we're not saying take that away from them. What we're saying is there is a reason that you have required medical doctors in this state for time eternal to do a residency and to have that experience and training. When you start to give that same authority to others, it brings into question for us, why is Dr. Powell doing his 3 years of residency? Is that not necessary to be able to prescribe? We think it is, and we think it should continue to be.
Thank you.
Thank you very much. Seeing no further questions, this concludes the hearing on House Bill 520. Is there? Oh, okay.
Thank you.
This concludes the hearing on House Bill 520. Thank you very much for your testimony today. We're going to jump to House Bill 625 because we have the Secretary of Agriculture here with us in our committee. So we're now going to move to House Bill 625. This is Human Relevant Research Fund Collection of Contributions Responsibility Entity. Delegate Cullison, Vice Chair Cullison, if you want to approach the table and bring your panel.
Madam Chair.
And I will point out for all the members that Vice Chair Cullison did already preemptively buy us dinner in the previous hearings.
Just fair warning, Madam Chair and friends of the committee. I promise this one's going to be shorter. Good afternoon, and thank you for the opportunity to present House Bill 626. This is the follow-up of a bill that we passed in 2023 to spur the development of human relevant research and drive the development of emergency research technologies that don't use animals in testing. So this was a bill that we discussed at length in 2023, saying that there are new technologies that allow us to, with more efficacy, determine the effect of different products on humans. When we passed it, we wanted to ensure that Maryland stays the leader in new non-animal testing methods and move to the front. We're already seeing the impact of relevant human technologies that they have on advancing human health and discovering cutting-edge solutions that animal testing could never have revealed. I was surprised to learn that 90% of the drugs that are seen as safe in animals fail when they go into human studies because there are biological differences between animals and humans. But under the previous bill, and I'm going to claim naivete on my part, the implementation of collecting the funds. So what this did is it created a fund that is actually a fee on every institution that uses animals in testing, and it's a certain amount per animal, and that's how the fund was created. And what we did was we turned it over to the Department of Health. In 2025, it was brought to my attention that no funds had been collected. as a result of the bill. And when I went to MDH to find out what had happened, they did not have the knowledge, experience, or capacity to do this kind of collection. They had no direct relationship to the animal studies in any of the institutions. So the only funds that came over, actually, because the funds are supposed to come through the agency and then go to TEDCO to make grants to companies to use the non-human testing, was voluntarily from Johns Hopkins University. But that was, I think, I heard $50,000 that they turned over just voluntarily, expecting to follow the law, and MDH didn't know what to do with the $50,000. Well, I've learned since then that it's actually the Maryland Department of Agriculture that takes care of animals. And they have, a whole department called Animal Health Program. They collect the information that we're looking for in terms of who is testing on animals, how many animals they have, what is the condition. And so any of those institutions that receive licenses from the USDA, information is going through our own Department of Agriculture. So I reached out to Secretary Addix. I can say that I had not met him before that, but now I know what a kind and generous man he is. And he actually said that he thought the Department of Agriculture could take care of this for us, could begin to accumulate this fund. I had a conversation with a pharmaceutical company. I know you're all surprised about that. And I was told that they're eventually going that way. Everybody's going the way of human relevant testing. And I said, well, this can help you go faster because you can actually get grants to facilitate building your infrastructure for it. So I want to thank Secretary Addix and his team. And I'm going to ask you, this is a chance for us to fix a mistake that I made and move forward with our intent to incentivize innovation, especially in our biotech activities. I thank you for your consideration and humbly ask for your favorable report, and I'll turn it over to the Secretary.
Madam Chair, Madam Vice Chair, member of the committee, my name is Kevin Addix, Secretary of the Maryland Department of Agriculture. Honored to have this rare opportunity to speak before your committee. We're usually across the hall. I can make this very brief because the sponsor outlined the purpose of this bill and why this would be a good fit for our department. We already deal in animal health. We already deal with USDA and APHIS, through which the programs this bill regulates, the statute regulates, are already registered. So we already have cooperative agreements and understandings with USDA and APHIS. While we currently have no formal oversight or relationship with animal testing facilities, as the sponsor said, we do have our animal health program, and so our folks are already attuned to and already have the relationships with the folks who would otherwise be regulating these entities. And if you choose to move this bill forward, we stand ready to support the effort.
Thank you very much for your testimony. I do have Abby Kolshretha from TEDCO on your sponsor panel. Oh.
It was actually TEDCO that alerted me to the issue that we were not collecting the funds.
Thank you, Madam Chair. My name is Abhishek Kolshretha. I am the Executive Director for the Maryland Innovation Initiative at TEDCO. As it so happens, my professional background is in drug discovery and drug development. So I think I was on my second day at TEDCO when I learned about this bill and became immensely excited about it. I'll echo Vice Chair Bagnone saying that this is a transformative opportunity in the field of drug discovery and drug development that has not only captured the attention of pharmaceutical companies and biotechnology developers, but also the federal government. The FDA has continued to make strides in the adoption of non-animal models, new approach methodologies, or broadly NAMs, in the development of new medicines. And they hold the potential to not only reduce the cost of developing new drugs, but also improve the efficacy and safety of those drugs as they're implemented. So we stand ready to implement this program. In the last year versus the $915,000 estimated in the fiscal note, we've been made aware that approximately $185,000 has been collected. Even with that amount, we've already reached out and engaged national partners who are scientific and regulatory experts in the adoption of these models to engage with our stakeholders here in Maryland to identify ways to evaluate, support, and ideally implement those technologies in the drug discovery and drug development process. We are underway with engaging those groups as we speak, and our hope is to have the first request for application or RFA out this summer of 2026. So even ahead of this bill being implemented, we stand ready to implement the Human Relevant Research Fund program, and we look forward to working with our colleagues at the Department of Agriculture to implement it further.
Thank you very much for your testimony. Are there questions from the members for this panel, the sponsor or her panel? Seeing none, thank you very much for your testimony and for bringing this bill. I do have one unfavorable, Laura Bogley. If you want to come to the table and you can start your testimony when you're ready.
Thank you, Madam Chair, members of the committee. Again, I'm Laura Bogley, Executive Director of Maryland Right to Life. The Board of Directors is asking for an unfavorable report on this bill, and we just want to use this as an opportunity, even though this isn't the most offensive of the bills dealing with human relevant research. We want to take the opportunity to remind the committee that the Health and Human Services, United States Health and Human Services has, and the National Institutes of Health, have recently ended federal funding for research using human fetal tissue derived from elective abortions. And that is involved in human relevant research in Maryland. That is legal to use human fetal tissue in human relevant research in Maryland. So, of course, we strongly object to human relevant testing methods that use the embryonic or fetal cells of tissue derived from aborted human beings. In human relevant research, science is designed to study human systems directly rather than using animal models. Human fetal tissue is in demand because it contains unique progenitor cells that have not yet committed to a specific role. But after nearly 2 decades of isolation of embryonic stem cells, there's not a single disease that these cells can cure. But destructive embryo research has proven to be speculative while simultaneously crossing ethical boundaries and taking human life. Not only is the research ineffective, it also creates incentives and increases the demand for aborted fetal tissue, including late-term fully developed human organs. So we just want to remind the committee that there are ethical forms of human relevant research that use adult cells rather than fetal or embryonic cells. There's also ethical tissue donation from miscarriage and stillbirth, where the parents donate the remains to science. So what we want to do is just encourage you to adopt ethical forms of research that are humane to human beings, as well as to the animals that we love. And for this reason, we ask for your unfavorable report.
Thank you very much for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 625. We're now going to move to House Bill 813. This is Maryland Medical Assistance Program coverage for the treatment of obesity. Delegate Martinez, if you want to approach the table and go ahead and bring your panel, and you can get started when you're ready.
Well, good afternoon, Madam Chair and members of the committee. For the record, I'm Delegate Ashanti Martinez, here to present House Bill 813. Obesity is a chronic, complex medical disease and is one of the primary drivers for healthcare costs here in Maryland and across the country. It is closely linked to some of the most expensive and debilitating conditions we treat every day in our Medicaid program. Type 2 diabetes, heart disease, stroke, high blood pressure, sleep apnea, joint disease, fatty liver disease, kidney disease, and certain cancers. These are not abstract risks, but more so, these are conditions that lead to hospitalizations, disability, long-term care, and premature death. House Bill 813 takes a practical and forward-looking approach to address this crisis. The bill authorizes the Maryland Medical Assistance Program to provide comprehensive coverage for the treatment of obesity, including behavioral therapy, bariatric surgery, and FDA-approved medications for chronic weight management. And if the department chooses to offer that coverage, the bill simply requires that Medicaid recipients be notified. Let me be very clear about what the bill does not do. This is not a mandate. This is not a mandate. This does not force the department to cover any specific treatment. It does not override utilization management, medical necessity criteria, or clinical guidelines. And importantly, there is no physical note attached to this bill. Although, if you look at the note, it does outline what the cost would be if coverage was required. To be clear on my intentions of the bill, I am proposing a sponsor amendment that would mandate the Maryland Department of Health to submit a state plan amendment to the Centers of Medicaid, and Medicare services to clarify that the program may cover certain weight loss drugs. This is because a state plan amendment was filed in March 2023 to reflect that Maryland Medicaid plan does not cover drugs excluded uses drugs for anorexia, weight loss, or weight gain. Replacing the 2023 state plan amendment means that as the market evolves, the Maryland Department of Health may be nimble and stay ahead of any administrative drafting and review hurdles in order to provide coverage. What this bill does do is send a strong and intentional signal from the General Assembly that Maryland should treat obesity like the serious chronic disease it is and give our Medicaid program the flexibility to modernize care accordingly. Right now, our system is often upside down. In practice, many Medicaid patients can only access anti-obesity medications after they have already had a heart attack or a stroke. In other words, we are paying for the ambulance ride, the ICU stay, the cardiac rehab, and the lifelong complications, but not for the treatment that could have helped prevent those outcomes in the first place. That, to me, makes no sense. From a budget perspective, this bill is also about cost avoidance, not cost exploitation. The most expensive care in our system is not preventative care. It is late-stage, crisis-driven care for advanced disease. Hospitalizations for heart attacks, strokes, kidney failure, amputations from diabetes, joint replacements, and long-term disability are what drive Medicaid spending. If we can reduce even a fraction of those outcomes by treating obesity earlier and more effectively, the savings to the system could be substantial. We are also seeing important changes in the market. As the news has reported, the prices of anti-obesity medications are coming down, and competition and broader use are continuing to push costs in a more sustainable direction. At the same time, the clinical evidence continues to grow, showing that these treatments can reduce not just weight, but the risk of diabetes, cardiovascular disease, and other complications. This bill is supported by a broad group of stakeholders. Obesity medicine specialists, healthcare providers, endocrinologists, cardiologists, all are increasingly viewing obesity as a disease that must be treated early and consistently, just like hypertension and diabetes. Patient advocates are also strong supporters because they see every day how untreated obesity leads to worsening health, reduced quality of life, and barriers to work and independence. The message from clinicians and patients is consistent. Treating obesity earlier is not about cosmetics or quick fixes. It is about preventing diabetes, preventing heart disease, preventing stroke, and preventing lifelong disability. House Bill 813 respects the role of the health department, but it also, by preserving its flexibility, it does not mandate spending, but it does say clearly and responsibly that Maryland should move away from a system that only pays after people get seriously sick, and towards one that prevents disease, improves outcome, and uses taxpayer dollars more wisely over the long term. In short, this is a patient-centered, physically responsible, and medically sound step forward for Maryland's Medicaid program. And with that, I respectfully ask for a favorable report.
Hello, Madam Chairman, Chairwoman, and members of the committee. I wanted to first thank you all for your public service and everything you do for the state. My name is Mihir Patel. I'm a physician board certified in internal medicine and obesity medicine, and a faculty member at the University of Maryland. And I practice both primary care and obesity medicine. But my remarks are my professional opinion and not made on the behalf of the University of Maryland School of Medicine. So when I think about the power of obesity medications, I think about several patients, but there's a couple that come to mind. So the first one is a 72-year-old woman. She has a history of a heart rhythm disturbance, sleep apnea, blood clots, breast cancer, and hypertension. And we were able to prescribe anti-obesity pharmacotherapy, combine that with other therapies, and completely transform her life. Thoughts of food don't consume her. We were able to cure her sleep apnea, and she does not need a breathing machine at all at night. Then I think of another patient that I saw last week. She's a 38-year-old female. She gained weight early in childhood because of mental health medication she needed. And I can't help but wonder, is she going to suffer the same fate that this other patient did? And we have the tools to treat her and prevent these things from happening. There are at least 200 medical conditions that we know of that are directly related to obesity. And we know that having obesity decreases life expectancy by 8 to 10 years, the same amount as smoking. So I believe that addressing obesity is the future of primary care and medicine as a whole. And rather than waiting to treat hypertension, kidney disease, liver disease, cancer, blood clots, we can treat obesity and reduce the inflammation that drives the development of these conditions. Maryland has consistently been a leader in the healthcare sector, especially in terms of quality of care. And as obesity medicine represents a new frontier of quality healthcare, recipients of the Medical Assistance Program in Maryland truly deserve this therapy. Please support them in voting in favor of this bill. Thank you.
Thank you. Thank you, Madam Chair and members of the House Health Committee. My name is Monica Bilger, and I'm the Director of State Government Affairs for the American Diabetes Association. On behalf of Marylanders living with obesity and those trying to delay or prevent the onset of type 2 diabetes, we are in strong support of House Bill 813, which simply opens the option of Maryland to consider obesity coverage by removing discriminatory language in the state plan amendment that excludes coverage for medications for weight loss, weight gain, and anorexia. The trends tell us that whatever we're doing right now is not working for Marylanders. Prevalence of diabetes and obesity have worsened over the past decade, and rates of those intersecting diseases continue to rise. Maryland is consistently in the top half of the U.S. states with highest obesity prevalence rates and diabetes. Without further intervention, understand that over 60% of today's toddlers will have obesity by age 35. Over 60%. But it is not as if we don't know how to change the trajectory. The health benefits of effective weight management with GLP-1 medications along with diet, exercise have been extensively and consistently documented. In a clinical trial, one GLP-1 medication cut the risk of adults with prediabetes and overweight or obesity from developing type 2 by 94%. Every year, 44,000 are diagnosed in Maryland with diabetes. This could potentially stop over 20,000 people from developing type 2. Sentiment held by some that such coverage is unnecessary ties back to longstanding biases with respect to obesity and does not sufficiently consider the broad and costly health and productivity impacts that result. Obesity is a chronic disease. The struggle is real, the disease is real, and it's one that disproportionately impacts communities of color and rural communities that face systemic inequities in life and healthcare. There's an urgent need for us to address obesity and diabetes, and this legislation is step one, not mandating coverage to prevent diabetes or prevent stroke or prevent the 13 types of cancer linked with obesity. No, this legislation just simply removes discriminatory language. Thank you for your time.
Thank you. Good afternoon, Madam Chair and the members of the committee. My name is Dr. Zubia Chaudhry. I'm Assistant Professor of Medicine at Johns Hopkins School of Medicine, and I direct their Obesity Medicine Fellowship. But today, I am speaking on behalf of myself and based on my personal experience, and I strongly support this bill to expand access to anti-obesity medication. I did not bring any data points for you specifically, but I want to tell you about one of my patients. She's a mother in her early 40s. She works full-time, cares for her children, spends years trying to improve her health. She has changed her diet. She walks every day. She followed every recommendations that I made to her. And yet, despite all of that, her weight did not improve. Instead, she developed fatty liver disease. She developed severe joint pain and struggled just to climb flight of stairs. She once told me through her tears, "I feel like my body betrayed me and I don't know what to do." This is the reality of obesity. It is not lack of effort or willpower. It is a chronic disease driven by biology. The body actively resists weight loss, making it extremely difficult for many patients to succeed through life's changes alone. And once patients do lose weight, the body does fight to gain it back. There was a silver lining in this whole story where she briefly was able to access anti-obesity medications through coupons and assistance programs. Over the 1 year, she lost 40 pounds. Her liver test improved, her pain decreased, and she could move freely. She felt hopeful and she felt motivated. But then what happened that she lost coverage. And I had so many stories like that. And what happens with stopping the medications, the weight loss, the weight does come back. Despite the fact that she maintained her lifestyle, that her weight returned, and so her comorbidities. We have a tool for obesity, but we lack equitable access to it. In addition to my clinical role, I teach obesity medicine to residents and all students, medical students, but that is where we kind of come and we halt that we cannot access care for our patients. Thank you, sir, very much.
Thank you very much for your testimony. I'm going to open it up to our members. Are there questions for this panel? Seeing none, I just had one question for Monica Bilger, because I was looking at your written testimony and I was really struck by some of the stats. 480 billion in direct healthcare costs, 1.2 trillion in indirect costs due to lost productivity. In Maryland, obesity is estimated to reduce economic activity by 11.2 billion annually. Can you speak a little bit to those numbers?
Certainly. Well, when you factor in the cost of the disease, now, for example, when you're living with diabetes, it's 2.5 times the cost to just live with it. Oh, sorry. It's 2.5 times the cost to live with diabetes than it is for someone that's living without it. The cost for having to miss work because issues arise with your chronic disease issues. And that's just in diabetes alone. Obesity is, as was mentioned earlier, is linked to over 200 diseases. So when you think about the loss of productivity, you're talking about missed work days, you're talking about having to remove yourself out of the work scenario, the impact it has on families and caregivers, the inability to just be able to be as productive as you'd like to be because of the impact of the other diseases that are instigated by the obesity. So it is a huge number. We're often talking about, what it costs to cover these medications, but we're not talking about the cost of inaction and allowing people to fall into the other disease states that are comorbidities linked to obesity.
Thank you very much. And Delegate Martinez, I just wanted to double check, because you mentioned an amendment that was coming. And looking at the fiscal note, you are correct. It looks like this is not a mandate. There's a projection of what it would cost. But can you just speak once again to the amendment, just so we're clear on what the bill does now and what the bill is intended to do with your amendment?
Yeah, so the amendment's just to clarify the language. The original intent was that we wanted the State Department of Health to essentially put in an amendment to the Medicaid plan saying we may pay for these types of weight loss or types of drugs for the treatment of obesity. Right now, we do not do anything for the treatment of obesity. And so I just wanted to make it very clear, and that's what the amendment intends to do. Yep.
Thank you very much. Seeing no further questions, this concludes the testimony of your sponsor panel. I do have 2 favorables that are virtual and then a panel of favorable with amendment. Do we have our virtual witnesses? Okay, just let the record reflect we don't have Selvi Raja Gopal or Susma Vadia in the virtual waiting room, but do we have Megan Roberts and Barbara Hofstein favorable with amendments? You go ahead and approach the table and begin your testimony.
It's not easy to get in here.
Okay, is this on? Yes. Good afternoon, Chair Delegate Bagnell and members of the Health Committee. My name is Barbara Hofstein, and I am a licensed and registered dietitian testifying today on behalf of the Maryland Academy of Nutrition and Dietetics, MAND, in support of Bill House 813, with an amendment to include coverage for medical nutrition therapy. MAND represents more than 1,000 registered dietitians across the state. Obesity is a complex chronic disease associated with many chronic health decisions, as you heard, and affects more than 1/3 of the adults in Maryland. MAN strongly supports ensuring access to comprehensive multidisciplinary obesity care, including pharmacologic therapies, bariatric surgery, and evidence-based lifestyle and behavioral interventions such as intensive behavior therapy, IBT, and medical nutrition therapy. HB 13 includes coverage for IBT, bariatric surgery, and weight loss medications. However, comprehensive clinical nutrition care provided by a registered licensed dietitian is missing. MNT is an evidence-based, personalized approach to prevent, manage, and treat medical conditions, including obesity, and is required by physicians in Maryland before performing bariatric surgery. Research shows that lifestyle interventions are a critical component of comprehensive obesity care. A systematic review of 62 randomized controlled trials found that patients receiving registered dietitian-led care achieved greater weight loss, reduced blood pressure, and improved quality of life compared to those who didn't. Can I just say that registered dietitians provide targeted dietary strategies to help patients better tolerate medications and remain on the treatment, which is essential for patients who are receiving GLP-1 by adjusting meal times. And I won't take any more time, but I hope that you will consider this amendment, and we are certainly in favor of this bill with dietitians there helping do the job.
Thank you for your
right.
testimony. Thank you. You can go ahead and begin.
Hi. My name is Megan Roberts. I've asked Dr. Patel to join me because I am the 38-year-old patient that he met last week. I've suffered from chronic illness since I was 8 years old. They discovered herniated degenerating discs in my spine when I was 8. So things like exercising normally are difficult for me. Since then, my health has declined, and now we're up to 5 herniated degenerating discs. My hips are shifted up and forward. I suffer from severe chronic pain all along my midsection. I've tried things like exercise, eating healthier, dieting, and according to Dr. Patel, I've been on any form of medication prior to GLP-1s or surgeries that can be given to me to help with weight loss, and nothing seems to work. GLP-1s for me, without insurance, are $809 a month. It's hard for me to work because I'm constantly in pain. I've been in pain management for the past 5 years, and even at that, it's hard for me to do. So imagine trying to spend $800 a month while working minimally and trying to support. I have two children in school, one in elementary school, one in high school. Imagine trying to support 2 children while spending $800 a month trying to manage your weight while suffering with chronic pain and not being able to do that while also suffering from chronic depression as well. There's a multitude of things to support this bill just from people like me.
Thank you very much for your testimony. Thank you for being here today, and we all wish you very well. Are there any questions from this panel, from our members for this panel? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 813, and we are going to move to House Bill 535, which is Food Establishments, Cottage Food Businesses, Maximum Annual Revenue. Delegate Ahrens, if you want to approach the table. And
bring up my panel.
And bring up your panel. Yep, absolutely. Thank you.
Good afternoon, Chairwoman Bagnell and Vice Chair Collison and members of the committee. For the record, I'm Delegate Steve Ahrens, here to present House Bill 535. It's a bill that increases the annual maximum revenue a cottage food business may generate from the sale of cottage food products. Although not to the scale of mass producers, cottage food businesses still need robust facilities to operate a food business effectively. Specialty equipment is not only required to keep up with demand, but also to bring a safe and quality product to their local customer base. Cottage food business owners are using the best quality and many times Maryland-sourced ingredients, and the current income cap of $50,000 is not suitable to keep up with the increasing product premiums. Increasing the annual revenue cap from $50,000 to $100,000 would keep cottage food businesses afloat, allowing them to continue offering products to the residents of this state. I have a situation when this bill came to me where neighbors of mine actually have one of these businesses, and it's amazing to me how many there are out there and what we can have an opportunity to do today to support a small business owner. We all know that inflation has hit us pretty heavily. The prices for food has gone up, the prices for the goods, the prices for equipment have all gone up. And I would urge the body to consider this. I think it's an important bill. I think it's an excellent bill for small businesses that helps generate income for Marylanders. And I'll let my panel of one speak.
Chair and members of the committee, my name is Essie Griffin, and I am in favor of the increase to the income cap for cottage food businesses. This change would strengthen small businesses and increase tax revenue for our state. As revenue increases, so does taxable income, expanding Maryland's tax base while encouraging responsible entrepreneurship. It would also directly support Maryland agriculture. As a bread baker, I personally purchase grains milled and grown right here in Maryland. When cottage bakers are able to grow, we buy more from local stores and farmers, keeping dollars circulating within our state. The current $50,000 income cap makes it impossible to earn a sustainable income. Once taxes and expenses are deducted, many are left earning near or below the poverty line. The current cap effectively assumes a baker has a secondary income or a spouse who can financially support the household. And this creates an unfair barrier for single mothers and other people who just do not have that privilege, but are working to build stable businesses. I personally experienced this firsthand. In June of last year, my husband unexpectedly lost his job. We knew we were capable of expanding my bakery to help sustain our family while he pursued a new position. However, due to the income cap and our projected sales, we couldn't grow, or else we would have exceeded that legal limit. So my husband had to change careers, and our family of 5 suffered for 6 months, not because we lacked work ethic, but because of the current income cap. Nearby states like Pennsylvania, Delaware, and Virginia, they do not have an income cap. I'm not asking Maryland to remove it entirely, only to raise it to better reflect today's economic climate. I also do respect that Maryland prioritizes food safety. Raising the income cap would not inherently increase the risk of foodborne illness. Bakers would continue operating under the same safety regulations that already protect consumers. Increasing this cap supports small business growth, and it benefits Maryland's economy. Thank you for your time and consideration.
Thank you for your testimony today. Are there any questions from the members for this panel?
Favorable. Excellent choice.
Delegate Ahrens, I just wanted to ask if you had seen the the testimony favorable with amendment from Macho. This is an interesting moment because the Department of Health is silent on this bill. And we're very pleased to hear that the cottage industry is doing so well, because I remember when we were going from 25,000 to 50. But Macho said that they were concerned about the sharp increase may have unintended consequences. They're proposing that an inflationary scale be applied to the revenue limit, regulated, updated, and clarifying to specify whether the revenue limit refers to gross or net revenue. Have you spoken with Macho at all?
No, I did not have a conversation with them.
Okay.
But again, we're looking at something here, this has not happened for quite a while, and when you look at the cap of $50,000 versus where we're trying to get to, and other states being unlimited, I think this is a reasonable request, and I think it's something that's going to benefit a lot of people in the state.
And I appreciate that. I also saw that there is favorable testimony from the Department of Agriculture, and I remember that when we went from 25 to 50, the sky did not fall, and it seems like we're doing really great, but I just wanted to give you an opportunity to respond. Seeing no further questions, this does conclude the bill hearing on House Bill 535, because there are no unfavorables, and we will move on to House Bill 672, which is, thank you very much, Public Health Maryland Pediatric Cancer Fund, entities eligible for grants.
Hello, friends. Good to see you all. It says do not press. Do I press or not?
Delegate Shetty, we'll turn it on for you.
It was turned off.
Yeah. There we go. We've got you. You can begin your testimony when you're ready.
Thank you. Thank you, Madam Chair, Madam Vice Chair, and friends on the second best committee in Annapolis that I dearly love partnering with very frequently. So thank you for allowing us to join you this evening. For the record, my name is Delegate Emily Shetty, here today to provide testimony in support of HB 672. This is a really simple, kind of a technical fix bill. In 2022, this committee did an amazing thing in establishing the Pediatric Cancer Research Fund in our state. As intended, the fund would provide dollars to help support important research happening here in Maryland. The fund was seeded with $5 million subsequently by the Appropriations Committee. Just last year, you all passed a bill that would establish the commission to actually decide who would get the money and how the grants would be distributed. During the process of creating the regulations for the commission, or by the commission, it was discovered that in order to get the money out, because the fund was initially drafted unintentionally to include for-profit entities as eligible grantees, it would require a multi-year-long RFP process. The intent of the fund was never to go to for-profit entities doing research in Maryland, but instead to go to our amazing nonprofit research entities here in our state. And so what this bill does is it clarifies that the fund is, the eligible entities to receive grants from this fund are nonprofit entities. That's what this bill does. It will allow for the funds to be distributed this year, so we don't have to wait for several years for these needed dollars to be distributed. I will add that in my subcommittee tomorrow, we have the Prevention and Public Health Fund hearing with MDH. That is where the Pediatric Cancer Research Fund sits. The department is ready to distribute these dollars. In fact, they have included it as part of their FY27 budget allocation. However, they cannot distribute them in this fiscal year unless this bill is passed. So with that, I respectfully ask your favorable consideration, and I, Madam Chair, with your permission, would love to have my sponsor panel testify.
Absolutely, and we brought up your virtual witness as part of this panel as well.
Thank you.
Chair Bagnell, Vice Chair Cullison, and members of the Health Committee, thank you for the opportunity to testify today. My name is Ruth Hoffman, and I'm here as the CEO of the American Childhood Cancer Organization, or ACCO. So in 2018, ACCO conducted a national analysis and found that only 2 states in the country funded childhood cancer research, while nearly every single state appropriated significant funding for adult cancer research. This gap exists despite the fact that pediatric cancer is the leading cause of disease-related death among children. That analysis led ACCO to work state by state to change this disparity. To date, we have helped secure more than $120 million in funding for childhood cancer research across 7 states, and Maryland has been a national leader in this effort with $5 million already appropriated. House Bill 672 builds on that leadership by clarifying Health General Article 20-120 to its original intent, ensuring that research dollars are distributed in a timely manner to nonprofit institutions that actually conduct the childhood cancer research here in Maryland, including our academic children's hospitals. These institutions rely on grant funding and are prepared to translate it into safer, more effective treatments without delay. But I'm also here as a mother. In 1987, I was good. So funny. My daughter was diagnosed with acute myeloid leukemia. She actually became one of the first children to survive a bone marrow transplant enduring toxic chemotherapy and total body radiation. But survival came with a cost. She's faced secondary cancer, endocrine dysfunction, chronic lymphedema, and now is actually facing heart failure as a direct result of the treatments used to save her life. It's been 38 years. It's amazing. It still hits so hard. But treatment for pediatric AML is still largely the same, and that's why this is so critical. In the past 30 years, only 7 new drugs have been approved by the FDA to treat all types of childhood cancer, compared to more than 220 drugs for adult cancers. Children facing cancer have courage, they have love, and they have resilience. What they do not have is time. And for these reasons, I respectfully urge your favorable vote on House Bill 672. Thank you for your leadership.
Thank you for your testimony, and we're so pleased that your daughter is doing so well.
Honorable Chair, Vice Chair, and members of the committee, good afternoon, or maybe it's good evening by now. Thank you for the honor of testifying today on behalf of the Johns Hopkins Division of Pediatric Oncology, of which I've been a member for close to 40 years, and which I've led for the past 18+ years before stepping down about a year ago. My name is Don Small. I'm a resident of Baltimore County, and I'm testifying to express my support to amend which entities are eligible to receive grants from the Maryland Pediatric Cancer Fund. As you've seen, it's very minimal, the revisions, and basically the effect of the minor revisions would be to restrict grant recipients to nonprofit hospitals, educational institutions, and other nonprofit organizations. The original intent of the bill was to enhance the limited funds that go towards childhood cancer research, and without the changes proposed in House Bill 672, the ability to achieve this goal is impacted. I've seen the impact that research has had on childhood cancers on the improved cure rate for children during my career. For example, pediatric acute lymphoid leukemia cure rates have improved from about 60% to greater than 90% over the time that I've been a pediatric oncologist. Eliminating for-profit companies from being able to access these limited funds is important to create opportunities for hospitals and organizations with less resources. Specifically, for-profit companies do have other sources of funds and do very little pediatric cancer research. I've been blessed with the opportunity to train scores of incredibly talented young scientists and physicians and to collaborate with brilliant colleagues during my almost 50 years as a physician scientist at Johns Hopkins. And most importantly, I've had the chance to help patients and families in Maryland and beyond. Support for pediatric cancer research has always been underfunded compared to adult cancers, comprising only about 4 to 6% of the National Cancer Institute budget. Yet when cured, these children have so much to contribute to society over many, many decades. I view the Maryland Pediatric Cancer Fund as an important step in partially overcoming this deficiency, and by making these changes, you will maximize the impact and benefit of these funds. On this basis, I respectfully urge you to approve these minor clarifying revisions to this law and move HB 672 favorably. On behalf of myself and the children I treat, thank you for your consideration.
Thank you for your testimony and for your work. Ms. Lewis, if you want to go ahead and unmute, and you can begin your testimony.
Hello, Honorable Chair and members of the Health Committee. Thank you for the opportunity to testify today. My name is Donna Lewis, and I'm a Maryland mother here because of my son Carson, who was diagnosed with osteosarcoma at 16 and died at 19. Carson had the perfect combination of fire, gentleness, and brilliance. He was strong, outspoken, and hilarious. But more than anything, Carson loved justice. In school and in life, he stood up for kids who were picked on, made them feel safe and seen, and fiercely protected them. That's just who Carson was, a fighter for what was right. He would have made change in this world, of that I have no doubt. Carson endured treatment after treatment, and in the end, he developed therapy-related AML, a secondary cancer caused by the very chemo that was supposed to have saved him. That's when we were told there were no more options. All treatment stopped and the clock began to count down. Children with osteosarcoma still receive almost the same exact chemotherapy used more than 40 years ago. The protocol hasn't changed and it isn't working. Carson was extraordinary, but his outcome was not. Too many families live with the same nightmare. When a child like Carson still has life in them, still has hope, and still wants one more chance of treatment, that child deserves it, and so does the world. One of these kids might cure a disease, one might change a law, and one might lead a revolution in care, but only if we invest. House Bill 672 ensures that Maryland's pediatric cancer funding goes where the actual research happens, nonprofit research institutions and children's hospitals, the ones best equipped to turn funding into real effective treatment. Families like mine are often told there's nothing more we can do, but that's not true. The truth is there are options, they just haven't been funded properly, and the world cannot afford to ignore that any longer. As such, I respectfully urge a favorable report on House Bill 672. Thank you for letting me speak Carson's name today. It would be this mother's greatest honor if change was meant to be, if the change he was meant to make in this world begins with this bill and with you. Thank you.
Thank you very much for your testimony, and we're very sorry for your loss. Thank you for being here today. Are there any questions for this panel? Delegate Hill.
Thank you very much. Thank you very much, Delegate Shetty, for this bill. I'm just a little confused. We modified it in 2024, but it was put in place in 2022, and you talked about the funds can't go out. So if there have been funds since 2022, do you have any information about who's been getting the funds? I mean,
Yes, I can happily answer that. Nobody has gotten the funds. The funds have been sitting unspent since they were first appropriated into this fund. They have been a target for reallocation to plug other parts of the budget. And we have successfully restored them for the last 2 to 3 years, 3 fiscal years, when they have been shifted to other priorities. Knowing that the commission was going to be sat, knowing that they would help get these dollars out. Once the commission was sat and this problem was discovered, I brought this bill forward so that we can distribute. There's not a single dollar has been spent from the $5 million.
May I follow up? And I'm sorry. So as I'm reading the bill, it takes out for-profit hospitals as someone who can receive, and we don't have any of those in Maryland, but I guess it's outside the state. And what's the other change that will allow, I'm not clear how the changes I'm seeing the bill allow the funds to go out.
So my understanding is as originally drafted, like for-profit laboratories were also eligible, and there just needs to be clarity that that's not the case, that it's only not-for-profit research institutions and the entities specified in the text that are eligible.
And that's been what's been stopping the money from going out?
So can I answer that one? So what happens, when the commission started meeting, we went through and established and wrote a scientific RFA because the funds will be distributed in a competitive grant process so that we have the best science possible. And so the intent was never that research would be done by for-profits, because children's hospitals in the state of Maryland are not for-profits, they're nonprofits. But as soon as it was interpreted that there could be a for-profit, we had to go from an RFA procedure to an RFP procedure, and the RFP procedure takes an additional 4 levels of government, an additional 2 years to get approval. So the earliest that we can get the money out the door will be probably 2028, maybe 2029, if we don't change this to basically just nonprofits that do the research.
So it's how it changes the
Yeah.
process, not necessarily, got it.
Yeah,
All right, thank
everything's ready to go. The RFA is written.
Okay, thank you.
Regs are ready. Yeah.
Thank you very much for this bill, and seeing no further questions, I just have one question for the sponsor, or anyone who can answer best. So everything's in place.
Yes.
With this change, we can get those dollars out the door. Would there be any problem with changing the effective date to get the dollars out the door sooner?
Not with me. No, let's do it. Let's change it. Let's make it an emergency bill.
I think you understand where I'm thinking.
Yes, ma'am.
Thank you very much. This concludes, I believe this concludes, yes, the bill hearing on House Bill 672. Thank you very much for your testimony today. We are going to move on to House Bill 882. This is the Consumer Health Information Termination Date and Mandatory Funding for the state's Consumer Health Information Hub repeal. If your sponsor panel wants to go ahead and approach. Okay. So I have on the sponsor panel Cynthia Bauer, Robin Elliott, and Jake Whitaker.
Should I scoot up? He wants to sit here? Yeah. Okay.
He must be on the end.
I think so. Okay. We'll just bring the chair back.
Oh.
No, I'm going to sit in the chair first.
Okay.
I'll bring the chair back. Thank you for your patience, committee. The last hearing was a little faster than I thought. But my name for the record is Delegate Aaron Kaufman. Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the committee. Like I said, for the record, my name is Aaron Kaufman, and I'm honored to once again be presenting a bill that has no opposition and no fiscal note. And I also want to thank Delegate Taveras for co-sponsoring this legislation with me. I respectfully request a favorable report on HB 882. I was so moved by the Hub's briefing a few weeks ago and the impressive work they do. I want that vital work to continue. Maryland has made nation-leading investments in clear health communications. In 2022, Madam Speaker Peña-Melnick established the Maryland Consumer Health Information Hub through HB 1082 to advance health literacy, plain language, and language access. statewide. The hub is housed at the University of Maryland Horwitz Center for Health Literacy and ensures that people can find and understand health information. In just 2.5 years, the hub has strengthened relationships with state agencies, local health departments, and community organizations across Maryland. It has developed and pioneered practical tools such as the Maryland Plain Language Checklist, the web content review tools, criteria for grants and media campaigns, and a plain language and language access planning guide. It also created the Maryland Health Literacy Organization SEAL program, recognizing agencies that institutionalize clear communication standards. The hub supports public health workforce directly. It provides health literacy training for community health workers to reduce misinformation and distrust, address cultural and linguistic barriers, and help residents navigate complex health systems. It offers webinars, convenings, and peer collaboration spaces so that agencies can share best practices and modernize communication tools. But don't take my word for it regarding the hub's effectiveness. As documented in the 2025 Maryland Legislative Report submitted by the hub, the impact of the work is measurable and statewide. Since July 2024, specifically alone, the hub has engaged more than 116 Maryland agencies and organizations and participated in over 160 community meetings and outreach events across the state. 90 webinar participants demonstrated significant increases in knowledge of health literacy and plain language practices, with average scores rising a full point from 2.6 to 3.6 on a 5-point scale. 74 professionals representing all 24 jurisdictions attended statewide convenings, and they reported increased confidence in implementing Maryland's plain language standards. Additionally, 83 community health workers completed specialized communication training to better support residents navigating complex health systems. The data reflects concrete, measurable improvements in Maryland's public health communication infrastructure. State and local partners have emphasized that implementing plain language as a routine way of operating requires leadership, support, coordination, and sustained infrastructure. The bill ensures the hub remains in statute beyond the current sunset date, allowing Maryland to continue institutionalizing clear communications statewide. It also, importantly, in this time of fiscal hardship, removes the mandatory appropriation requirement, providing fiscal responsibility and flexibility while preserving annual reporting and oversight. The legislation does not expand regulatory authority. It merely sustains a communication infrastructure that improves transparency, strengthens public trust, supports language access, and advances Maryland's broader public health goals. For these reasons, I respectfully urge a favorable report. Thank you, Madam Chair. I'm now going to turn it over to Jake from the Hospital Association, if it's okay.
Great, thank you,
Madam Chair.
Great, thank you, Madam Vice Chair and members of the committee. I'm Jake Whitaker on behalf of Maryland's hospitals and health systems, here to testify in strong support of House Bill 882. So as you know, hospitals already make every effort to make sure that patients have the information they need, including through discharge planning, through patient portals, and even kind of personalized information for patients from the providers. And we think providing this information is critically important, especially under our unique hospital model, where preventing the number of readmissions is critically important. So making sure that patients have that information and so that it's clear and understandable is really important, and the hub does a lot of work to make that happen. I also want to point out another important piece. It's not just healthcare information, but it's health insurance information that's available in the hub. So it's not that the hub actually provides information, but it helps make that information more accessible. So as you know, payer denials are on the rise, and patients are allowed to appeal those denials by insurers, but oftentimes those coverage criteria, the denials decision, the timelines, they're very complex, and even an insurance lawyer might have trouble kind of navigating through those processes. So what the hub has done has kind of created plain language so the average consumer can really understand those processes and process those denials. So we think this bill's gone a long way, not just to make sure that patients really understand their health information, but so that they also understand their health insurance information. So for the aforementioned reasons, we respectfully request a favorable report on House Bill 882. Thank you.
Hello, and very nice to be with you here all again. Thank you to the chair, the vice chair, and the rest of the committee. We're very appreciative of the support that people have been offering to continue the hub. Since I was here with you on January 22nd, we have instituted some of the changes that the committee requested. I know that some of you were not there at the briefing, so just briefly to remind people of what the hub does. As the delegate and the Hospital Association representative described, we create the network in the state of Maryland that helps provide that communication infrastructure that is very unique in terms of what Maryland is doing and other states have not yet invested in. You've heard from many patients today during the rest of this hearing time. Their stories represent just a fraction of the challenges, the confusion, the complexity of our health and healthcare system that everybody is required to navigate. Jake was just referencing, claim denials and how people figure out all these very complex processes. What the hub has been able to do is work with organizations all over the state to try and make plain language sort of the routine, the default position. So since we met with you on January 22nd, we've added a consumer section that's available right from the homepage of our website, and it links to some of the resources that were referenced in the written testimony that's been provided, as well as the oral testimony here today. So we link, for example, to the Patient Bill of Rights that the Maryland General Assembly passed a number of years ago. We link to resources from Cooperative Extension that services counties all across the state. We link to our resource on Good Questions for Good Health, which helps people prepare to have those conversations with their healthcare providers. And in addition to the data that Delegate Kaufman's team provided, I wanted to just share with you that we've trained over 747 partners in plain language. We've presented to over 1,429 partners about health literacy in plain language, and we've shared best practices with 443 professionals. So again, I really want to thank Delegate Kaufman and Delegate Taveras for being willing to sponsor the hub's continuation, because I think we're doing what we can to make sure that information is accessible to all Marylanders. Thank you.
Thank you very much. And I see that Robin Elliott has just walked in. So Robin, if you would like to take a moment and breathe. All right, you can start your testimony when you're ready.
Breathing is a little overrated. Yeah, I know, we're in the health committee, I shouldn't say that. Oh gosh, who am I? I'm Robin Elliott. I am representing a group of federally qualified health centers, school-based health centers, school nurses, and occupational therapists. Very, very appreciative of Delegate Kaufman's sponsorship of this bill, as well as the work of the Consumer Health Information Hub thus far. And I know it's been 3 years. It's been fantastic. I have seen the hub's interaction with our state agencies. I know they do really incredible work with local health departments. And I feel every day when the things that we talk about in this committee that you all consider, it all hinges upon consumers understanding the information in front of them, whether it's eligibility or public health. And most of us, like me, I'm not very good at creating information that is really digestible and usable by the consumer. So I'm really happy that we have experts in Maryland. And so I think this is a great bill and would ask for a favorable vote.
Thank you very much for your testimony. Do we have any questions from the members for this, for the sponsor or this panel? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 882, and we are going to move to our last bill of the day, which is House Bill 860, the petitions for emergency evaluation, Arnaud and Magruder Memorial Act. Delegate Alston, if you'd like to approach the table, and I believe you are the sponsor panel? Yes. Well, as our now speaker says, you are enough. So when you're ready, you can go ahead and start your testimony. And we'll just give a moment to transition.
Grab a paper. If I could have my intern Chica join me for questions, technical questions.
That's fine.
This is her first bill hearing, so. All right, good afternoon, colleagues. My name is Tiffany Alston. For the record, I'm here asking for your favorable report again for the third time for House Bill 860. For starters, this committee and the House Judiciary Committee passed this bill unanimously in 2024, 22-0 in this committee, 22-0 in Judiciary, and 141 votes on the House floor. Again, in 2025, we passed this bill 23-0, 22-0 in the two committees that it was assigned to, and 136 votes on the House floor. I wish we did not have a need for this type of legislation, but the reality is we do. The reason I brought this bill is because in Prince George's County, we've lost 2 officers in the line of duty. Both of those sheriff deputies were lost serving an emergency petition. The person that they were trying to take to the hospital to get medical care killed them. It is unfortunate that we need a bill to specify and clarify that law enforcement officers, when dealing with patients and serving a civil order to take someone to the hospital, are allowed to use necessary and proportional force. So I have tried for 3 years to work with the opposition to come to consensus on this bill. I believe it has gotten much better over the years. I actually have yet another amendment that we will be presenting. The amendment office didn't get it ready for today. But that amendment says that nothing in this bill will prevent the law enforcement officer from using best practices in their own judgment to determine how force is implemented. The reality is this: when we have a person who is in a mental health care crisis and a court of law has ordered that this person be taken to the hospital to get medical care, and law enforcement or even doctors and medical providers have to go and get this person and take them to the hospital, possibly against their will, sometimes, not always, but sometimes, force is necessary to get them to the hospital so they can get treatment. That is what this bill is clarifying. Now, I think it is important more now than even when I first introduced this bill that we pass this bill, because we've passed it in our House and the Senate has not. And I think if this came before a court where someone used force, there may be a question on whether or not the General Assembly intended for people, for law enforcement officers, to be able to use force when serving an emergency petition, because now we have this legislative history that is incomplete because the bill has not been passed. So it is important that we pass this legislation to protect and stand with our law enforcement officers, to protect and stand with our public and to protect the very patients that are meant to be served by this bill. The second part of this bill authorizes the extension of the emergency petitions, because a lot of times what happens is people abuse the system, unfortunately. They are requesting emergency petitions time and time again, and there is no mechanism for the judge to even see the history. And sometimes it's rapid fire, and maybe they meet the qualifications, maybe they don't. But by allowing an extension, the judge can actually look to see what was the original complaint. Are those same behaviors that are dangers to the person's life, health, and dangers to others, do they still present? And what is the good cause why this petition has not been served? Because the reality is sometimes 5 days is just not enough time if you have a person who is in a mental health crisis and that person is homeless. Sometimes law enforcement just may not be able to find them to serve that court order and take them to the hospital. So the extension process is to streamline it so that people aren't coming back reinventing new things. It's so that the court can have a clean record of what has happened and be able to look to determine whether or not it is appropriate to extend this petition for emergency, to extend this emergency petition so that the person can get to the hospital and law enforcement can have time to serve them. Or maybe the judge looks at it and says, no, you were just here last week. We don't believe that these same things are presenting, so we're not going to grant it. But let the judge decide, and let the judge decide with the background information. That's what this bill does. There's going to be a clarifying amendment that we will present in subcommittee that will clarify that the 30 days starts from the date of the original issuance of the emergency petition. And then the other amendment, which I'm hoping will provide less consternation for the Office of the Public Defender, is the one I mentioned at the outset, which is nothing in here, nothing in this bill will prevent law enforcement officers from using best practices, their own discretion in determining how to implement force. But we have to stand with our officers, because I don't want another death, especially not on my watch, of a deputy trying to serve a civil order to take someone to the hospital. So with that, colleagues, I would ask that you issue a favorable report again on this bill so that we can protect our citizens, protect our law enforcement officers, and get people the mental health care that they need. Thank you, and I'm happy to turn it over to my intern to answer all of your questions.
Welcome to our committee, and this is the first time you're here? Is that correct?
Yes, this is the first time.
All right, I'm going to open it up to our members. Do we have any questions for this panel? All right, I see a real question from Delegate Taveras.
Thank you.
Thank you, Madam Chair. And thank you for bringing this bill forward, Delegate Alston. My question is surrounding the fact that there are individuals that recognize that or at least their family recognizes that they have a need for mental health assistance through the AOT emergency petition program, but they don't see that need. Yet they're terrorizing the individuals that live within the home, and they're committing crimes under the context of their mental illness and entering into court battles, no? So how is this bill addressing that to ensure that those individuals, despite they're going to the doctor, they're coming out and getting a free willing pass?
Thank you. Thank you for your question, Delegate. So I think it's two things. One, we have a combination of legislation that we've passed to try and address what happens when someone is not compliant with their medication. This bill helps your scenario because what it does is it gets people in a hospital setting, which is more appropriate than a prison setting. You said sometimes people are committing crimes. And sometimes when you go to serve them with the emergency petition, they may assault a law enforcement officer, not necessarily because they intend to, but because they're sick. And I would much rather have them go to the hospital to get medical care than to have them go to jail and be punitively punished because of their sickness.
Yes, ma'am. This is the case that I had mentioned prior. To me, that's the test case for the effectiveness of the AOT. This is an individual that has multiple cases before the court system. The mother does not speak English. She's terrified of her son, and his sister is terrified of her brother, and they have to live with him. When she went to the courthouse, they were able to get him before to go there, but once he was mandated to go to the doctor, he said, no, I don't want treatment. He's back in the house. I don't see that process I don't see what you just said in the process of what just occurred.
That would be a different bill. This is not necessarily the AOT bill. This bill addresses the process. So after your person, your constituent or person you know went to the court and they were granted that emergency petition and they got that civil order that says go and pick this person ABC up and take them for treatment, this is what happens after or during that court process. So the first part of the bill will, one, say that it conforms with the standard use of force guidelines that we have in the public safety article, which is necessary and proportional and all the things we did under police reform. So we just reference that. Other thing it does is it actually gives an expiration date because sometimes law enforcement officers are confused if the order is issued today and they have 5 days to serve it. Is it 5 calendar days, 5 business days? Is it 5 times 24 hours? It gives a date and time specific as to when that order expires, so there's no confusion. And finally, what it will do is in the event that the order cannot be served, it provides a mechanism to get an extension. Your concerns, as I understand them, address what happens when people are just medically non-compliant. And I think we've passed other legislation that's not necessarily this bill to address that. And there may be more work we can do, and I'm happy to work with you on that.
Thank you.
Thank you. And I'm just going to take a couple questions, try and clarify, because you have done a lot of work in this space. The emergency petitions is very specific to people who are being petitioned because they meet that dangerous standard, dangerous to self or others. Is that correct?
Yes.
And those who are eligible for assisted outpatient treatment would not be through the emergency petitions process. Is that correct?
That would be separate, correct.
That would be separate. And you know this because you were actively engaged in the civil protections, the civil rights protections of all of that legislation. Is that correct?
That is correct.
Okay, thank you very much. Delegate Hutchinson.
Thanks, Madam Chair. Thank you, Delegate, for 3 years of trying hard, and I know you're passionate about this, and it's always caught my attention. I think it is a good bill. How rare is it that we have a quorum of 141 to nothing when it votes through? So what's happening, what's happening on the Senate side? I see you don't have a cross-file. Are the opponents getting to that side, or is it just not getting the time of day? I'm just curious of why we're here 3 years in a row.
That is an excellent question. I don't have a cross-file. I have been working with our colleagues in the other chamber to try and get this bill passed, and I'm hopeful that this year will be different.
Thank you. Hope so, too.
Thank you.
Delegate Johnson.
Thank you, Madam Chair, and thank you again, Delegate, for this bill. Some of the parameters, like the Chair has stated, for emergency petition is presents a danger to their own life, safety, or that of others. So while I understand wanting the judge to see a pattern, do you think under those parameters, 30 days is too long, and considering the best interest of the patient or others?
You know, I actually went back and forth with the timeline, and the reason we came to 30 days, and they have to be renewed in increments of 5 days, it's really so that they can find the person and get them to the hospital. And I think that a judge will ask themselves the question, if it's been 10 days, and while they may still be presenting the same behaviors that show they are a danger to themselves or others, but they have survived for 10 days, maybe the judge says, no, I'm not going to issue it under the provisions for extensions. Under current law, what happens is your 5 days expire, you go back to court, you get a different judge, you file for a new one, and we saw evidence where it was the same exact petition. This was in a work group I was in. The same exact Xerox petition being presented to different judges time and time and time again. And in those cases, the person was actually being taken in over and over again. So that was an abuse of the system. So the purpose of the extension was to try and stop the abuse of the system, because it's no guarantee that the same judge is going to see the paperwork. But if it's an extension of a petition that's already been issued, then that original paperwork will be there for the judge to see it. But you'll have to show good cause as to why didn't this get served. And you still have to show that the same behaviors that precipitated the need for the emergency petition in the first place are still there and presenting. And if you can show those things, then you can get it extended. Otherwise, it won't get extended.
All right, thank you. Thank you, Madam Chair.
Thank you very much. All right, I see no other questions from the members, so I just wanted to circle back on something that you said, Delegate Alston, because you said, despite the fact that we've passed this bill numerous times, that you have continued to work on it and it has improved. So can you speak to how that has improved, and have you extended the stakeholders with whom you're engaged on this bill?
I've not actually extended the stakeholder group. I did have a very good conversation at the end of session with one of the senators about amendments he was interested in seeing, and we discussed how to address it. I hope that this addresses his concerns. I think what's happened is we just have a fundamental disagreement in the community about whether or not emergency petitions are necessary. And because some people believe that you should never emergency petition anyone, I don't know that we'll ever truly be able to reach a consensus on this. I wish they weren't necessary, but they are. In my opinion, they are necessary. And my concern is when we reach the point where this petition is necessary, I want to make sure that everybody involved is safe. And so I have tried, I have worked with my good friend who's going to come up and testify in opposition to this bill from the Public Defender's Office to make it better. But I think that fundamentally they just disagree with the process. And I don't want to speak on his behalf, but I do believe that we have made strides to make it better, and even today to make additional amendments to make the bill better. I think that as a committee, we do need to look at the emergency petition abuses that may be taking place, but that's not this bill. And I don't want people distracted by the comments and some of the testimony. It's valid, but that's not this bill. Like, this bill does not deal with people abusing the process. This bill deals with making sure our law enforcement officers are safe when serving one of these petitions where they don't have a choice, where a court has told them to go and serve this civil order of emergency petition and take this person to the hospital. They have to be safe. The person has to be safe. That person's family has to be safe. And we want to clarify the standard and just clarifying how we can get extensions. and the expiration date. I think everybody actually likes that part because we're all clear on when this thing expires, date and time, just like we do with a protective order.
And just to be clear, Delegate Alston, thank you for that. I know that this bill, the impetus was that high utilizers work group in Prince George's County, but during the interim, did you engage with the Mental Health Agency of Anne Arundel County, their crisis intervention team, Talbot County Sheriff's Office, any other stakeholders that you brought into the fold?
Yes, thank you for that. I did, and even this morning, before coming here, I had a conversation with Anne Arundel County about this bill and the new language that we're waiting for the amendment office to send over that says that nothing in this bill will prevent an officer from using best practices, so those national best practices, including de-escalation, and whether or not to even use restraints. Nothing prevents them from making those decisions. So, yes, I have engaged with them. Thank you.
Thank you very much for your testimony. I see no further questions from this panel. We do have one panel of unfavorables. So we have Keith Lotridge, Crystal Williams, and Michelle Libshin. You can go ahead and approach the table, and you can start your testimony when you're ready.
Where do you want to be? Apparently I'm going to know.
You can begin whenever you're ready.
And thank you. Good afternoon, Madam Chair, Vice Chair, and members of the committee. I'm the Deputy Public Defender for the state. My name is Keith Lotridge. I'm here to ask for an unfavorable report on Bill 860. First, I want to acknowledge that this bill is different from last year's bill, and we appreciate the efforts by its sponsor, who I think just left. Okay, I'll go a little deeper into that. The sponsor in this bill has been very approachable. She's reached out to me multiple times. I've spoken to her while I was on the side of the road because she is that committed. I appreciate the fact that she's taken the calls, and she has made every effort to make this bill a little bit more palatable to myself and the people in my agency. Having said that, today I'm here to testify because our office has grave concerns about emergency petitions as a whole and their use in the state. I want to speak specifically to the suggested amendment that we put in our written testimony. Most notably, we are requesting that language be added to the bill whereby every jurisdiction, county, to use designated mobile crisis teams to serve these emergency petitions where possible. I believe this bill is meant to make Maryland safer. That is unequivocally the driving motive behind this bill. And to be safer for both the persons being served and for those tasked with serving these petitions. We agree there's a great need for this effort. But the best solution is, wherever possible, utilize persons that have been extensively trained in addressing and calming persons in potentially troubled mental states. As a practitioner of law, a public defender, I have represented many people who have been served emergency petitions and got criminal charges because of them. I will tell you quite frankly that they do not react well to people approaching them in uniforms with police cars behind them. We do have a fundamental problem with emergency petitions, but we do think there are solutions and ways to do this safely. So we're just asking for an unfavorable at this time. And again, since the delegate's now back, if I may take 2 seconds, I want to thank the delegate for her efforts in working with us on this. Thank you.
And if I may, Madam Chair, I did get a message from one of the other witnesses. I should have stated so before Mr. Lutledge started his testimony, but Ms. Lipshin is over in the Senate testifying, so she did indicate that she would get over here as soon as she could. Thank you very much. You're welcome. And Madam Chair, Vice Chair Coulson, and members of the committee, thank you for having us here today. I am just here to offer some additional supplemental testimony in addition to our Deputy Public Defender, Mr. Lotridge, who has testified about our general opposition. And what I'm here to testify to today is just as an attorney who's currently in the mental health division, and I have represented individuals who have been emergency petitioned, it is important that I highlight, some of the things that we do see in terms of the racial disparities that still exist with emergency petitions. And so we are still very much concerned about the practice, and we know that this bill is not aimed at that particular issue, but it is something that we would be remiss if we did not testify to that here today in terms of what we see and the disparities that do exist in this practice. And we know that based on our internal data, while Black Marylanders make up only about 1/3 of the percentage of the population, they do make up more than half of those who are emergency petitioned and who are then held involuntarily and detained through involuntary admission. And so we are very much still concerned about how these petitions are being used in Black and Brown and indigent communities where they are traditionally underserved with mental health services, where they do not have the appropriate capacity or accessibility to mental health services in the community. And so we urge this committee to continue this conversation. We welcome and we really are grateful to Delegate Alston for her work on this, and Chair Bagnell for also welcoming us into the emergency petition work group, where we were able to observe those conversations and discussions, and also to continued conversations about potential amendments on this measure. And so we just want to make sure that we are addressing the primary concerns that we have as representatives of these individuals when they come in, and we are seeing things that need to be addressed as we continue to look at how emergency petitions are practiced and carried out and used throughout the state of Maryland. And I will just highlight one other additional issue is not only with children, but we are seeing an increased use of emergency petitions on elderly individuals. So I just want to highlight that as well as a noted concern. But thank you very much.
Thank you for your testimony, and thank you for continuing to engage with the bill sponsor. Do we have any questions from the members for this panel? Let me start with Vice Chair Cullison, followed by Delegate Hill.
Thank you very much, Madam Chair, and thank you for your work. And I appreciate the concept or the acknowledgement that there are a lot of social determinants in these particular issues, particularly lack of access to mental health care. But in these cases, we are talking crisis at that moment. So, Mr. Lottridge, you mentioned you thought that there were safer ways. So can you expound on that, what your recommendations around safer ways in these crisis situations that will make sure that essentially everyone survives and folks get the help they need?
So to acknowledge the premise of your question, this state has a severe lack of mental health resources for people in our poorer communities. And it's fundamental, and it's, quite frankly, having a significant impact on everyone, most especially my office, which is the place where, quite frankly, this often lands. But to directly answer your question, so one of the reasons we want mobile crisis teams is that these are experts who are trained and may not be in uniforms, may not show up in a police car, and who may have prior relationships with the persons involved. The Anne Arundel County model, which I think you, Delegate Alston, I know has spoken with them, and I'm a huge fan. Quite frankly, they know a lot of the people in the county who potentially could be subjected to this. When they are called or when they are used, there's already a relationship. This is not someone they haven't seen before. This isn't the expectation that they will be taken to jail. Because quite frankly, and I'm not going to talk specifically about the cases I've represented people in, but I do know that the people who I've represented have reacted poorly when the police that they've never met before are approaching them. They're still armed, there's still a police car behind them, and the anticipation of those individuals who, quite frankly, are probably going through something relatively traumatic in their life, their anticipation, their anxiety skyrockets. Having people who are trained specifically for this, and I'm not trying in any way, shape, or form to denigrate the police officers who do this. I know a lot of them. They're amazing individuals who put themselves at risk for this, but that's not their sole job. Having people whose sole job is dealing with this is what I'm talking about. And basically having the best operative plan in approaching people in these crises. Doesn't mean that they'll work in every situation. There will be situations where, quite frankly, officers will need to be called or certainly be the backup. But in many of the situations, having this first crisis intervention team, this mobile crisis intervention team approach is a much better and practicable option. Quite frankly, we don't have enough of them across the state. It is something, one of the reasons we would like it in the bill is we would like wherever possible, we have a problem with these petitions. We think they're used improperly, they are abused at times, and there's too many. Where possible, we would like to start addressing that. One of the places to address that is in every bill that comes up talking about a mobile crisis team and start having counties invest in it. It's for their benefit, and it's certainly for the benefit of the officers and the community. Did that answer your question?
Somewhat. I guess I'm wondering, again, it's about, dealing with something very quickly. And so I'm wondering, could there be training specifically among police around these issues? I mean, is this something you've recommended?
So,
right, using best practices when they have to, respond to these crisis situations.
So I will note that, for instance, the Anne Arundel County team has a program, and there are other programs for police officers to be trained on this. What we're saying is that in other states they have programs which aren't police officers. Doesn't mean the police are no longer involved, but it means that you're not showing up in a uniform and it's not your day job. You're for instance, a licensed clinical social worker or someone who is specifically trained for this type of intervention and someone who's in a time crisis and a mental health crisis. And that is the sole focus of your education.
Okay. Thank you. Thank you, Madam Chair.
Delegate Hill, followed by Delegate Taveras.
Thank you very much. And maybe it's been a long day, because I feel like I'm going to ask the same question that Vice Chair just asked, because I didn't get the answer. So I understand, if I understand you correctly, Ms. Lockridge, that, Deputy, you don't think that we should ever have law enforcement to enforce these petitions. You think it should always be a mental health professional who's trained to talk someone down. Is that accurate?
I very rarely give absolutes on anything, so no. I think that other people in my agency might give you an absolute on that. I'm not going to say it should never be something. However, I think that in every case, the people on scene, one of the persons on scene should be someone who is more extensively trained than a normal police officer would.
So the problem I'm having is that you've worked with the sponsor for year after year. I don't see an amendment on the bill saying, in addition, I mean, the essence of the bill is the 5-day extensions up to 30 days. You're talking about something that's important to the topic, but it's really not the bill. So I'm waiting for the amendment or the offer or the change or the alternative legislation that addresses your specific concern that will require, to the extent practicable, that a behavioral health specialist be on the scene. This bill, what am I missing in this bill that addresses your concern?
And I apologize. I didn't specify we did have written testimony, and we wrote it out in the testimony. I'm sorry.
Right.
I should have read that, because I'm sure that someone wrote it better than I said it. That we were suggesting the addition of an amendment. The petition shall be executed by a designated mobile crisis team where, and I'm not wearing my glasses, where possible.
More practical, okay. And so are you saying that with that amendment, you are in favor of the bill? Because I'm still seeing that you're in opposition.
That would probably be correct.
All right, then that's the answer to my question.
Delegate Taveras.
Oh, thank you, Madam Chair. Ms. Williams, you highlighted the fact that this tactic was being used on seniors. Are we looking at seniors with dementia?
So that is actually a good question, because a lot of times symptoms of dementia oftentimes present as behaviors that could be confused or misinterpreted as psychosis or issues that could cause an individual to be emergency petitioned. That is often one of the things that we do litigate in terms of elderly individuals who come in on emergency petitions in terms of whether they were properly screened or assessed for issues that may be attributed to aging or other medical issues that they might have, underlying health issues. Another main concern is that once you reach a certain age, certain medications don't work the same way as other medications. And so there's a real danger and concern about psychotropic medications and how they're being used on this particular population as well. While there are some medical professions that are trained specifically to treat individuals in the geriatric stage, not all of them are. Individuals are being brought to the emergency room and they're being processed through that. Throughout the entire state of Maryland, there may not be that particular specialized focus for that population of people. But yes, they are being brought in on emergency petitions where they have been, I've had clients who have been released where it could be underlying issues of dementia or other issues unrelated to a psychiatric crisis.
Just a quick follow-up.
Yes, but before you do, I just want to clarify your question because you used the word tactic. Are you referring to an emergency petition or are you referring to the wrongful utilization of, or overutilization of emergency petition?
She said that there was an overutilization.
Okay, that's what I just wanted to clarify. Thank you, because I think your response spoke to the fact that they were being utilized for a demonstrating behavior, but it might not be an underlying mental health issue. Am I correct?
Correct. And hence my follow-up with, could it not be potentially used for elder abuse, fraud or elder abuse?
Potentially, yes. There are certainly instances where, there is a question of the intent. And again, I believe Delegate Austin spoke to, we know that this is a situation, when you have any system, it could be abused. Any practice that could be abused or misused. And I think the important piece to take away from here is we need more education. We need more services. We need more folks in the community, focus in the community on how to help individuals who have particular issues or needs that might be overwhelming to certain families or family members. Are they getting the help that they need, or are they simply turning to this court intervention, police intervention, or looking to it as an answer or a relief to something where there's not enough oversight or scrutiny in terms of how the emergency petitions are being used?
All right. Seeing no further questions, I have a follow-on question. Because on Delegate Taveras, did you bring up this concern about elder abuse through the emergency petitions process in the work group discussions on this bill?
Madam Chair, you asked if I had brought that issue up?
Yes. At any point, did you bring up a concern about elder abuse with the overutilization of emergency petitions during the work group?
I did not. I know that I was there as an observer, so I did not offer any additional information about that, but I certainly would be happy to have that conversation with you.
Okay, thank you. All right, seeing no further questions, this concludes the bill hearing on this bill, which is House Bill 860, and concludes our bill hearings for today. Thank you very much for your testimony, and to our members, just let us know when we're down.